Hello, welcome everyone to the joint conference Genopole and Scanbalt event. We are delighted to host you, to welcome you here today. So toward the European health data space. So we have a full morning with a lot of exciting, with an exciting program that I can show you right now, so you will not get lost in your during this morning. So can you share the screen, please? Okay, so first of all, on the first session, we have an institutional talk, informative talk about toward the shared data space overview and state-of-the-art ambition and strategy with Mario Jędrosek, Marius Kalliola, Andres Metzpalu, and a panel discussion then on the model of governance for an institutional governance of the use of health data. On the second session, we have practical views from professionals with Adrien Delattre from the AFM, Charles Vestegem, Timothée Sinober, and then the panel discussion followed, moderated by Dr. Laurent Pépin. And finally, we'll have some technical and practical recommendation from the joint declaration we have conducted, we have elaborated together with Scanbalt, Genopole Scanbalt, on this proposal from the European Commission. I would also like to thank the French presidency of the European Union for labelizing us. It's really important. And all the work that has been done during the course of this presidency has been tremendous. And we really thank the French presidency to labelize us on this event. So without any further delay, some opening words from Genopole and from Scanbalt representative. Laurent, would you say a couple of words?
Hello everybody, bonjour tout le monde. Some word in French, quelques mots en français. Nous avons l'honneur d'être labellisé présidence française de l'Union européenne et il se doit donc d'avoir un mot d'introduction en français. Voilà, donc nous sommes évidemment extrêmement heureux à Genopole d'accueillir cette conférence vers une infrastructure des données partagées en Europe. C'est extrêmement important pour nous. Genopole s'affiche ici au niveau national, européenne et international. C'est une volonté affichée par notre direction. Tout d'abord, je tiens à excuser l'absence de notre directeur général, M. David Baudet, qui est souffrant ce matin. Je pense d'une maladie bien connue en ce moment. Voilà, ça c'est le problème actuel. Donc, Genopole est extrêmement heureux d'accueillir cette conférence au niveau donc, national. Donc, c'est une volonté de Genopole de s'inscrire dans cet événement et de renforcer la volonté et le débat et d'inscrire ce débat au niveau du citoyen français et européen sur les données de santé qui sont évidemment un but extrêmement important pour nos concitoyens en Europe. Voilà. Donc comme l'a dit Alexis, cette conférence donnera un aperçu des différents problèmes et différentes discussions qu'il y a sur les données de santé en Europe. Voilà.
Thank you, Alexis. Merci Laurent. Please, Janus, if you want to say a couple of words about Scanbalt. Here you go, Janus. Oh.
Yes. Can you hear me?
Oh, can you maybe if you speak loud?
No. I think it's okay. Good morning. I'm happy to be here, and we had the great cooperation with Genopole, Alexis, and the team, and we are very grateful that the French presidency has actually been supporting this, our main aim from Scanbalt for the further cooperation in Europe. So I would like to give, for those who are not familiar with Scanbalt, a couple of words. Like 20 plus years ago, 21 years ago, to be exact, a group of people from Baltic Sea region came together in Teschow in Mecklenburg-Vorpommern to actually discuss how it can be further developed cooperation around Baltic Sea and the Northern Europe in biotechnology, in genomics. And those people just didn't ask what governments can do for them, but actually proposed what they can do for the common good. And Scanbalt was founded. Now the Scanbalt is as we call it, meta-cluster, bringing together 24 biotech, health tech clusters. And cluster, we mean a triple helix organizations where you have regional governments, companies, research institutions. And we have been successfully coming through these 20 years based on public financing European projects, coming from initially from mostly genomic and biobank issues and projects to digital data nowadays, but still concentrating also the bioeconomy. So, like 2 years ago, when the European Commission was starting to forward an idea of the European common data rooms and including health data space, we immediately grasped and started to bring together different players. And in early 2020, Scanbalt organized an inquiry to get opinions on this common health data space from 32 different clusters around Europe, and which ended with a conference organized under the auspices of the German EU presidency and the declaration, which was used as an input presented to the German government to formulate a white paper. So meanwhile, we have been working with Portuguese partners under Portuguese presidency, and now we are in the French presidency. So we are happy to introduce and to host this meeting together with Genopole, and I hope that these discussions will have a very, very good repercussion in the future years to come. Thank you very much.
Thank you, Janus.
Thank you.
Thank you, Laurent. Thank you, Janus. I agree with you. I think this partnership is aimed to be a long-standing one, and we'll continue this effort of promoting the European health data space and health in general through Europe by partnership. Thank you, Janus. Without any further delay, because the time is running really late already, I would like to welcome Marcus Kallioka from EHDS toward the European Health Data Space Initiative. Marcus, are you with us?
Yes, I'm here. Can you hear me?
Hello, Marcus. Thank you for joining us. Okay, so
good morning.
Okay, so now we can see you. So thank you, Marcus, for coming here. So I will let you introduce yourself. I think you will be way better than myself to do this. And the floor is yours because the time, as you know, is running late. Thank you, Marcus.
Yes, thank you. And thank you for the invitation to this event today. So my name is Markus Kalliola. I work for the Finnish Innovation Fund, and I am a coordinator of a project called tehdas towards the European Health Data Space. So I will speak you today on behalf of being the coordinator of this project. So regarding the Finnish Innovation Fund, I have one slide from my organization. So we are a public organization under the Parliament of Finland, and our aim is that the Finland prospers in the future in a manner that is sustainable. And for that activity, we do a lot of think tank work, but also experiments in the society, and we find a lot of public sector innovations. I hear quite a lot of noise from the background. I wonder if you have microphones still open. All right, so going to the data then. We are here today to talk about data, European health data space and health data. But we need to put the health data into perspective with the other legislation. Since the General Data Protection Regulation was established in 2016 and came into force 2018, there has been a lot of strategies and legal initiatives. Some of them are already in force, and some of them has been approved, but they are not yet in force. But I think in these slides you can see that there has a lot of data regulation that have shaped the way that we use data. And most of them are horizontal, so they are also applied into the health sector. But as you can see, the last proposal there, which was given on May 2022, so last month, relates to the health data, and I think that's also the topic of today. One word regarding the data strategy, that's actually foundation for a lot of the initiatives that you saw in the last slide. The aims are that data can flow within the EU and across sectors, that there is a lot of availability for high quality data to create and innovate, that we respect the European values and rules. So we don't want to mimic the models from that other regions have developed for the data use. It might be state related, like in the East, or like in the West, mostly in the private sector. But we want to have them based on privacy and European values. And of course, we want to create good governance mechanisms that are good for all, for the society, for the organization, and for us individuals. Now, before I start to tell you about the project that I'm coordinating, the European Health Data Space proposal is now out there. And my project that I'm coordinating is mostly focused on giving guidance for the European Commission and the member state regarding this proposal. So now that the proposal is out there, the European Health Data Space has actually been defined, and a lot of the elements that are in there has been at least proposed by now. So now it's up to the European Council and the Parliament to create the compromise text before the proposal becomes final. So how it has been defined in the proposal is that the European Health Data Space is health-specific ecosystem comprised of rules, common standards, practices, infrastructures, and governance framework. I think the key takeaway from here is that it's not a single IT system. It is not a single way of operating. There are multiple infrastructures, standards, and then they are governed by a governance framework. And if you see the next slide, I think this explains it even further. It's the slide from the European Commission. The scope of the European Health Data Space is both primary and secondaries of health data. So it empowers individuals to control their data. It makes a single market for data. And it, for example, allows individuals when they're traveling to get access to their health data, and healthcare professionals to treat patients when they're traveling, or individuals to get access to their medications in pharmacies abroad. For their reuse, it creates new institutions, what are called health data access bodies. It defines how health data can be used for the secondary purposes, what data is available, how data permits will be granted, and so forth. So it really creates the framework for the health data use. It's not based on a single IT system. I think the health data space many times gives us a wrong understanding what the European Commission has, what it has aimed, and what is the final scope of the European Health Data Space. But I think we have a lot of time to discuss this today. Now, moving on to the TEHDAS, what we have done and what is the project about. So it is a joint action. It's a financing mechanisms from the European Commission. And our aim is to support the member state and the European Commission in developing and promoting the concept of sharing data for the secondary use. We are a project. We have 25 European countries involved, and we started working in February last year, and we will work until August 2023. The project is coordinated by the Finnish Innovation Fund. Here you can see the scope, and as I said, the European Health Data Space is both primary and secondaries of health data. The data scope is focused on the secondary use for better policy making and better research and innovation. We focus mostly on the legal governance, data quality, and infrastructure topics. Here you can see in one slide most of our goals, so and our thematic areas that we function. So we have started to work on the governance side, and we have published already quite a lot of results there. So how do we think that the European health data space should be governed, and why it should be governed from the health perspective? We have published results from the data quality as well, from the semantic interoperability and data quality assurance perspectives. We have published our generic architecture for the secondary use of health data, as well as how we have proposed a federated network for the European health data space, and we had then proposed also how the federated network should work, what should be the functions of different nodes in the network, and so forth. We have also published a user journey that I have a picture for you later in the presentation. So how the researchers get access to the data and what are the different steps they need to take. We have discussed what's the role of citizens, what kind of data altruism mechanisms there could be in the European health data space, and final sustainability. So how this all should be financed, and how the stakeholders can be involved in the process. So in the sustainability work package, we are quite a lot of engaging with the external stakeholders in different kind of events as well. So as I said, I will not have time to explain all the outputs that we have published from the project. They are all accessible from our website, data.eu, and you can go there and look yourself. But I have selected a couple of examples that I would like to briefly explain to you. So in the beginning of the project, we defined why health is a specific case in data legislation. As I showed you in the first slide, there have been a lot of horizontal regulation in the data and data use. And for example, the Data Governance Act was accepted this year, and it gives horizontal guidance for reuse of any public sector data. But health data is a specific data set, and we defined in the beginning why we think that health needs to be specifically regulated within the data strategy. Also, we analyzed what are the barriers currently for the cross-border sharing of health data for the secondary use purposes. And we also published a document giving options how to overcome these barriers. We did quite a lot of reviewing of scientific papers and interviewed or asked for case studies. What are the real examples from real life, how these barriers are hindering the data use? And for me, I think the main thing was that out of 11 kind of like categories, 6 were linked to the legal problems. So cannot be solved from bottom-up approaches, building infrastructures or doing things from that perspective. Because if the problems are legal by nature, they cannot be solved with the regulation. So they are, for example, how to have common definitions of what's the secondary use, what are the purposes for data use, what is enough pseudonymization that it can be approved for cross-border use and so forth. 3 were linked to semantic or data. 1 was only linked to infrastructure, and 1 for citizens' trust and trust in general. I think we many times think this on a different perspective. We think that it's the infrastructure that is hindering the data use. That if we just have a good infrastructure, if we have good IT systems, then things are solved. But this study showed that it's mostly actually legal problems that we are facing. On the data quality topics, as I said, we have proposed what should be in the legislation that should be legally bound, and we had 3 proposals for the Commission put on the proposal. There should be metadata that should be published for all data holders. There should be regular audits, and how you process data should be published. At least the metadata catalogs were present in the in the proposal that came out on the 3rd of May. On the semantics, we have identified 23 interoperability standards and how they could be used in the European health data space. This is the overall architecture that we have proposed. I think it's a pretty busy slide and hard to explain in a short time. But I think the key takeaway for the secondary use of health data in EU is there will not be a single source of data. Data will not be gathered in one IT system. What we have proposed, and what is also the proposal from the Commission, is that there will be kind of health data access bodies that we call nodes in this architecture, and they will then be connected to each other, but there will not be a single silo for data or so. And data will be always accessed to secure processing environments that you can see here in the slide. And that is also what the proposal states that was given last month. This is my final slides on the outputs from TEHDAS. As I told you, we have defined the steps to access data that we call the user journey. It starts on the left-hand side from data discovery. Then you need the data permit to use the data. Then you need to get this data, and you can use the data in a safe environment. And then you finalize the project and you publish results and so on. So this is the basic things, but of course we have written quite a lot of details on each step and how they function, so you can find it out from our outputs. Finally, I would like to invite you to Stakeholder Forum next week. You can register on our website. It's a hybrid event, so please come there if you want to hear more what we have done and what the stakeholders think about our work and the European health data space. Thank you.
Thank you very much, Marcus. Thank you very much for your really informative presentation about the European perspective, a strategical perspective, which will be really helpful for the audience to understand a bit more about the European health data space. So now we will have a more national perspective connected to the European one with Mario. Mario, are you with us?
Yes, I am. Thank you.
Yes. Hello, Mario. Thank you for joining us. So you've heard what Marcus said. We will have some time to discuss about it during the panel discussion. Mario, I let you open your presentation. So maybe you can say a couple of words about yourself and the work you have been conducting at the Health Data Hub, and then I'll let you start. I think you have a lot of really interesting things to say to us. Thank you.
Okay, thank you. I think you can see my slides. Okay, yes. Yeah, so thanks also for inviting us. So I'm Mario Jondrasek from the Health Data Hub, a French national authority unit gateway to health data. And I'm working there as the European projects lead. So also very much on focus for this session. So I think from what I understood, our attendees have a quite good knowledge already of what the Health Data Hub is. So I will only reintroduce it in 2 minutes, and then get on to the perspectives of the European health data space from our perspective, without delving too much on our other activities. But I'm available for any questions, of course, and there are more slides in the backup on the Health Data Hub in case you're interested. So to get started, the Health Data Hub is there with one main mission, which is to ensure easy, unified, transparent, and secure access to health data, with the ultimate objective to improve quality of care and support for patients. And that is our objective, both at the national and also on the European level, to do everything to achieve that mission, which is currently based on 2 observations: that health data can be very, very important to improve healthcare and public health. But today, at least in France, we have got very good data, but it's very scattered, compartmentalized, and it takes very long to get access. So we want to contribute to improve that. So we've got our main mission is subdivided into 4 submissions. So the first is being the unique gateway to health data in France. So if if a researcher wants to access health data in France, they send their data access request to us. And then afterwards, there's a process based on, national process based on GDPR, where then there's an ethical and scientific committee reviewing the request, and then the French Data Protection Authority finally approving and delivering the data permits. Then the second role is we've got a collection of databases that we can make available, which includes one of the largest medical administrative databases in the world, which is based on the French Health Insurance Fund, and also a number of other databases in our catalog, which is increasing more and more. Then we've got a very secure, actually one of the most secure platforms that exist on the market, as certified by the French authority in the matter, to allow researchers to conduct their studies in a secure research environment. And finally, we've got a number of tools for the ecosystem to bring together stakeholders and to work together on a health data culture. So I don't have the time today to present to you exactly what each of the submissions mean in practice, but yeah, as I mentioned, feel free to reach out to us in case you're interested. And then, as Marcus has already described, health data sharing is a major priority for the European Commission and a major pillar of European health policy. So the solutions from EU side in that matter are multiple, but especially they're both legislative instruments and project-based instruments. So Marcus has spoken specifically around the joint action TEDAS, where we are also involved as a national contributor, as competent authority. And then we are a candidate actually for another project, and I will talk about that just in a minute. Just before that, also a few words on the European health data space legislative proposal that was published on May 3rd. So I don't go into all the context here, but just to say that now, of course, there's a process ongoing with the European Parliament and the Council of the EU involved to negotiate and adopt the final proposal, and then the proposal will only apply sometime after the adoption. So these rules won't apply as of tomorrow. And then there's also some tertiary legislation in terms of implementing and delegated acts that will need to be put forward after the formal adoption of the text to go into more detail around some specifics. So if we look at the contents, just for a bit broader context, again, covers, as Marcus said, primary and secondary use of health data. But what is also interesting is it suggests in the Chapter 6 a common European governance and coordination mechanism, which would cover both primary and secondary use of health data. And while some European governance already exists around the primary use of health data, this will be completely new for the secondary use of health data part. So we're looking very much forward to that, to go beyond just project-based collaboration. So I will jump this. So I will just talk 2 minutes around some of the impacts of the proposal as it stands on the secondary use of health data, at least from our perspective, and so mostly from a French perspective. So as we see it, the proposal could address some of the barriers that exist today or that we are facing today around the secondary use of health data, and especially lead to a reduction in the time to access the data. So the proposal includes time limits for both data holders to provide data and the newly created health data access bodies to provide the data to the researchers. So those time limits, if they are followed, would speed the process up quite considerably in France. Then with the creation of health data access bodies who would be the ones delivering the data permits, the roles and responsibilities in the data access process, at least in France, would change considerably. And of course, there would be a common framework for those rules and responsibilities throughout Europe, which would make European requests much easier. So requests that concern more than one country, or requests from another country to use data in another country. The proposal also defines what categories of data are in scope. And in France, again, right now there's some uncertainty around some categories of data, or where some actors are not quite clear around which data are in scope of the current French legislation. So this proposal could also make that clearer. Then there's proposed a common framework for access fees, which is quite close to what is also in the Data Governance Act. So there's some level of what the proposal says, that some of the costs for collecting data could be included in those fees for private entities, but not for public entities. So for some of the actors that is positive, for others it is less positive. The proposal also defines some requirements for the secure processing environments. So for us, that means that we need to check that our platform, our secure research environment corresponds to all of these. But I'm quite confident about that. Then related to the harmonized rules for access, and the other important part to be able to realize projects mobilizing data throughout, in other countries or throughout different countries, is to be able to discover which data is available and how it can be used. So the proposal includes a common EU datasets catalog and the data quality and utility label. Then there's the proposal includes reference to the GDPR information rights, that no individual information is required in all cases, which is quite pragmatic, but that general information is always required. And finally, as Marcus has already described, there's the health data at the EU infrastructure. So I'm available, of course, for questions around, and we will discuss, I think, the legislative proposal in more detail later. And so, as I mentioned before, there's two main projects that we are involved in at the Health Data Hub with regards to the European health data space. The first being the TEDAS, a joint action which Marcus has greatly described. And then there's the European Health Data Space pilot project, for which the Health Data Hub is leading a candidate consortium. So we don't have an official response from the European Commission yet, but hope to receive an answer soon, and hope, of course, to be successful. So that consortium would like to build a first test version of the European health data space for secondary use, connecting the data platforms at European levels, both national platforms, European agencies, but also international research infrastructures and associations. And then to test the services that we propose to put in place through a number of cross-border research use cases, and based on that, make recommendations for the future long-term European health data space for secondary use. So just for my final slide, what the network is trying to achieve, or how it would be for project leaders to use our network in some extent. So there would be a common metadata search portal where the data of all nodes could be discovered. Then we want to put forward a common data access portal with a single data application form, so that a researcher would only need to submit one form, which would be given to all nodes, and to have then the different national processes running. But for the project leader, it would be the same as just one process, because there's one single form that they have to do. And then the project leaders could access the data through the different nodes and run their research project. So that is what we propose to do with the European Health Data Space pilot, to show what is feasible on the European level and what the value add of such a network compared to the current situation where every researcher needs to figure out their own way would be. So I think I'm at the end of my allocated time, but you're happy to answer any questions and looking forward to discussion later.
Thank you, Mario, for your really dense, important presentation. I think it was really important to enlighten the audience on the regulation. The regulatory aspects are one of the key thematic of our event today. Also, it was important to emphasize the fact that there is always a link and connection between different European initiatives. So, as you can see with the Marcus and EHDS, and hopefully with the European Health Data Space, we hope that we will get funded for the pilot and the implementation of the pilot. But now I would like to call, and this one not from distance, but is with us on site, Andres Metspalu from Estonia. So Andres, you will explain us a bit an example of user case of implementation of initiative at the local level. So just I will help you with that. Don't worry. Up. So the floor is yours, and good luck.
Thank you very much, and it's really, I don't have a mic here.
Maybe you can, wait a sec.
Can I have a mic, or I just talk?
Do you have a mic? I'm sorry. Up.
Okay, it's nice to be back. I used to come to Genopole a couple of times before, because genotyping and sequencing was already going on here a long time ago, and we learned a lot. So I'm going to talk about like a user case. You know, why you are doing this in Europe? Why you have to really prepare to share the data? And so, of course, the problem is that you know, why we are doing this genomics and all these things? Because we want to improve the public health. We want to be people more healthy, to live longer without disease, and not suffer like 25 years before you finally die. I would like to get sick in the morning and die afternoon. And you know, this would be the ideal thing. So 23 years ago, Jaanus was head of the university hospital, and I was a professor of biotechnology. And the new government came, and they were asking new ideas. And we proposed to do the Estonian Biobank, Estonian Genome Project. And Jaanus presented it to Prime Minister, who was 27 years old this time, and told, look, this is crazy enough, let's do it. So you have to have a political support in order to do biobank in small country where country has no money. And we got 64,000 euros just to get going. We established a foundation, and then we traveled with Jaanus to US every second week, I would say, just to raise money. Finally, we raised money to recruit 10,000 people, and infrastructure was up. So the vision was that we have to really make a population-based longitudinal volunteer cohort. Of course, medical community was against it. Everybody was recommended collect cancer, collect eye disease, collect cardiovascular. Why do you need collect healthy people? We have sick people, enough sick people. But you know, 20 years later, it turns out the population-based approach was probably the best thing to do. How we understand it now. So now we have more than 200,000 people with health records and lots of data. Everybody's genotyped, and 3,000 are sequenced deeply in order to use imputation on array data. And we have biobanking law, which makes it available for other researchers. Everybody can use. We are collaborating all over the globe and publishing one paper per week last 10 years. And I would say this is 20% of our adult population. And now we are already introducing population-based approach for prevention. Next 10 years, the main thing will be prevention. And we have to put more attention to prevention. Healthcare budget are using 1% of money for prevention. It's definitely not enough. And in our biobanking law, of course, in addition just to collect data, to analyze it, it's just to use the data to improve public health. So this is the plan is, and this is what we are doing, just to use the polygen risk score as a major risk factor you know, after Framingham risk factors, which happened like 50 years ago, you know, systolic blood pressure, cholesterol, lipids, nothing really big thing came until genomics is now available. So I predict that everybody, let's say 10 years from now, everybody knows their PRS on their major disease risk, and not, they don't remember anymore what the glucose or cholesterol value is. And the main thing is that we have to kind of sequence about, let's say, 1% of population in order to have a good database for imputation. Then use SNP arrays to genotype. Basically, we have to genotype everybody. You know, not everybody wants to be genotyped. Not everybody wanted to be vaccinated against COVID, and they were ready to die, but they don't care. And lots of people don't care. So we have to accept it. And then use PRS. You just have to run this array, costs 50 euros altogether, recruitment up to the QC in the database, and you just can use this array data for anything where you have a genome-wide association data, and including pharmacogenomics. And then you just use these risk scores, and on primary care level, you can give advice to primary care doctor, look, this is what this person's risk, and you just have to focus on this one. And you just can really improve public health. This is, we believe that it's true. So, of course, doctors don't have any idea what genomics is and what is SNP is, but they have to read it, which decision support tools provide them. And they have to communicate it. And now it looks like it's very nice just to communicate it directly, like I'm doing here. But, you know, it was okay also to just get it from the screen. And there are pilot projects in Finland and in our place also that we see that people, lots of people are happy, especially now after 2 years of training of Zooming and you know, teaming and all this. People are getting more familiar with this thing. And you look, healthcare is also going to change because, you know, we don't have a post office anymore. We don't have a bank office anymore. You know, we are doing all, and the whole shopping malls are disappearing, especially in US because people, Amazon is winning. And I predict that also the big hospitals are not going any big anymore, but they will be also kind of federated thing. People would like to go into a smaller place in where they get without queuing just to get into the thing. So decision support systems, this is what we have to develop, and here we are a little bit behind. So polygenic risk scores, this is what we have born with. If you have a higher cholesterol, then you are getting already sick. So if it's just dripping from the sky, we don't have to be a really, I would say, genomic scientist to predict that soon it's going to be rainy. But if it just predicts this rain 10 years earlier, then you have to be smart enough. So this is all thing about this polygenic risk score. And I know lots of people don't believe it, but gradually the believers are winning over. I would say, when I'm talking to doctors, so I would say that quite often I convert them from Protestant to Catholics. So let's take an example. So it was not directly, it was just the people are protesting, but Catholic country. So if you just take all breast cancer patients, you see that there are people who are kind of having higher risk and some people who have a lower risk. But if you just take the top 5% of risk, then you see that all women have we all know that about 6% of all women either get ovarian cancer or breast cancer before they get 70 years old. But these top 5% are getting the same thing 20 years earlier. So mammography starts at 50, most countries, including our country. Lots of women are gone before they get this letter. Moreover, even worse, if you get the letter, only 60% will go to mammography. So if we just can really write that, look, you have a high risk of breast cancer, why don't you come to the screening? So I would say that we get much more people to really come, and also we invite them 10 years earlier. So I believe that there is a huge potential to improve. And this is not only breast cancer. Now we can do PRS for hundreds of diseases as soon as you have enough data. And now the data comes into, because this common disease, common variant, that means in order to find this tiny genetic risk factor, you have to have a huge cohort in order to get enough power. That's why we have to collaborate globally, and also in Europe. That means we have to share the data. And also use the data from different countries. So this is why we have to do this data thing. So we returned data from biobank to 5,000 people. And, ethicists are really worried that, people are getting, upset and confused and tense and so on. Nothing. People really like it. And, I just interviewed some of them, and people telling, look, I have been visiting doctors last 15 years. Today, finally, they told me what is my problem. So it's basically, I would say, doctors. We trained 80 doctors, 80 family physicians, which are 10% of our family physician workforce. Say that, look, finally we have something which is scientifically proven to tell to people. Otherwise, we just are looking and talking, nice things, but just measuring the blood pressure and glucose and cholesterol and send them home. But now I know you have a risk of glaucoma, and you have to go to eye doctors, and you just can prevent your losing your sight. So this is all about. So how can we do it across Europe? So basically, a few years ago, 22 countries, now we have 24 countries joined together, and let's do they called it 1+ million genome. So that means that it's not only about genome, it's lots of other things. And unfortunately, 2 large countries like France and Poland are still observers. Ireland and Switzerland are also observers, but I hope so soon we are all together here. And but we have 12 working groups, which covers everything from governance to the COVID, and there are several user cases. And so basically, the idea is not to you don't have to invent the bicycle in every country. Let's do something together. And we can learn from each other. Of course, advanced countries like France or Scandinavian countries or Netherlands, they are moving much faster. And the countries, which just recently joined the EU, they have to learn, and they have to really catch up very fast. And this is a European principle. We have to have the same quality of healthcare in every corner of EU. And I guess this is a really good goal. So there are 12 working groups. I just only mentioned a few of them. So it's common standards and minimum data sets for clinical and phenotypic data. And this is important, because if we just do it, everybody is doing it differently, we can't really share the data, because we have been collecting differently, quality control is different, so we have to have some common principles. Good sequencing practice. Ivo Kut, very well-known fellow here, because he was running the genotyping facility for a long time. Now he's in Barcelona. Sequencing is technically not difficult. Data analysis is difficult. And now good news is that basically the price is going down. Last 7 years or so, prices didn't really move. Illumina had a controlling situation, and now $100 genome looks like around the corner. And we see this is 100, let's say, euros once in your lifetime. If you just buy 2 bottles of good wine, this is all what it costs. And I guess everybody could do it, not really waiting when government pays for it. So whether it is secure in databases, so this is again what we heard now. And there is a new project called the Genomic Data Infrastructure, 40 million euros across Europe. So also databases will be improved, and the tools how to share the data. Now data are not going to move. Tools have to come to the data, and this is necessary. So Gene of Europe, this is a new thing, and this is why we propose the Gene of Europe, is that we would like to sequence 500,000 new genomes on purpose, just to get the maximum genetic variation from Europe, and use this database to impute arrays. Also, if sequencing is still like 100 euros, genotyping is still 5 times cheaper. So in order to really cover the full population, my vision is that we have to sequence the newborns, and we have to genotype the adults, and in 15 years of time, everybody has the genomic data. Of course, arrays are not good for newborns. There's so many de novo variants. There is something which you have to do it now, and these first projects are showing that if you sequence almost in 10% of the cases, you have something to do immediately when you sequence a newborn. So, but for us, you know, arrays are good enough because we already survived the childhood diseases. And now we are looking like cardiovascular, cancer, diabetes, which are having hundreds or thousands variants. Everybody has a tiny fraction, but you can still manipulate your lifestyle, your environment, and probably there is a pill to take it. So it's this is a gene of Europe. And I'm running in this gene of 1 million genome project, one working group which is common complex disease, including pharmacogenomics. And basically, I'm proposing the same thing for Europe what we did in Estonia. You just have to genotype, to use the PRS, use the decision support, which is AI-based software, and find people from the population with high risk for certain disease, and then use this information for intervention. Whether it's a lifestyle change, whether it's a statin taking, or whether it's just following or doing more frequent screening test. And for certain people, you can do less frequently this screening test. But you know, if you just look into the population, we have 200,000. Everybody has something. There is not a healthy person. And if somebody claims that, you know, I'm healthy, you know, we have to study a little bit more carefully, and we find something. So the problem is with medical community that we are approaching healthy people, not patients. And you know, some doctors don't get it. Why should we really deal with healthy ones? But you know, you have to start early prevention. If you do it when people are sick, then we have a problem. So it's not only technical things. I guess technical things we can do, but there are lots of other things we have to do. And I'm really running short in time. But you know, there are professional public trust we have to achieve. And this is most important. This means communication. And I guess the lack of communication was a failure in some countries, including us, to achieve the vaccination on high numbers. We managed to do like 70%, which is really not good. We have to also focus on inclusion and equality. But because this array is so cheap, we can do it on everyone. And you know, MRI is expensive, but 20 euros for chip is not much. And sequencing and facilities and personnel, because if it grows in volume, of course it's easy to buy instrument, but then you have to have a technicians who can run it, then you have the informaticians, and then you have the data scientists. So you have to have a full team. You know, it's like F-35. There is one pilot, but 25 people on the ground who make sure that this thing can land after the flight. So IT infrastructure, this has to change. We, even small biobank, we have 2,000, more than 2,000 terabytes of data. And do all this computation and analytical tools. Now the budget, I remember when we didn't pay anything for IT thing. Now we are paying 700,000 per year to this high-performance computing center. So it's an item already in the budget. So it's getting expensive. And of course, a legal environment, financial arrangement, and then, of course, most countries have to do some pilots in order to convince local people, including politicians. You know, problems, of course, give me a break. There are tons of problems, and I can invent even more. But we have to solve the problems. Problems are there just to be solved. And of course, there are PRS, and GWAS are not clinically validated. It has to be changed. Algorithms, there is no golden standard for PRS calculation. Everything is fast developing, but it will be there. And if you are waiting when everything is fine, nothing happens. You have to start using it. If 4T model 1909 didn't start driving, so we don't have a Mercedes or Citroën as we have today. We have to use what we have and then improve when we're doing it. And you know, And here, I guess, I would like to thank my colleagues, and this is our team. Thank you very much.
Thank you very much, Andres. If you want to take place, we'll start the. Keep your mic up. I will bring one. Thank you, Andres, for this very interesting presentation. I will now start the round table. So we have both Andres and Ines from France Médecine Genomic, and we have also people from outside the previous speakers. So we'll be discussing what we have already discussed in the previous session, but more into details, try to have an interactive talk about those questions that could be raising in the audience. So please, I will inside. Are we connected to Mario and Marcus? Yeah, Mario and Marcus, you are still there?
Yes.
Okay, perfect. Thank you for staying with us. And we can start now the discussion together. So first of all, maybe Ines, you can introduce yourself because you were not part of the previous speakers, so it would be interesting for the other audience to have a grasp on your activities.
Okay, so good morning, everyone. I'm Ines Amadou. I'm the International Affairs Officer for the 2025 French Genomic Medicine Initiative, which is a national initiative that started in 2015 as a request of the Prime Minister at the time, made to the French Alliance for Health Sciences, for Life Sciences and Health, avons. And the idea was to develop at a national level an initiative that will make able to sequence genomes of the population, mainly rare disease and cancer patients, and integrate this sequencing into the healthcare pathway. So that's what we have been doing in the name of the Alliance, so that federates all the public institutes in France that are working in health and life sciences. And just to give you a quick overview of where we are now, we have two running sequencing platforms that cover the whole French territory. So once again, for rare disease patients and cancer patients. And we are building a national infrastructure called the CAD. So it's the national, let's say, data analyzer and collector, which would be the cloud of all the genomic data that will be stored and analyzed after sequencing the patient and the population, and that will be a service provider infrastructure for research, for industry, for healthcare professionals, and that will be at some point connected with all the initiatives you saw here.
Exactly. I think all the panelists here are more or less connected and their initiatives, so it's really important that we discuss together to understand a bit more what would be the challenges we could face and how we could surmount them together. So I will go straight to the point, and my first question will be to Marcus or Mario. Maybe Marcus, since you were the first speaker. So Stella Kyriakides, the commissioner, stated that the European health data space is a fundamental game changer for the digital transformation of healthcare in the EU. Would you agree with this sentence? I believe you do, but if you can explain a bit more, what could be the impact of this initiative on a broad scale?
Well, thank you, Alexis. I really think it is a game changer. I think for multiple reasons. If you start from the primary use of health data, so what it means for all us individuals, if you travel to another country, it has now, since today, it has been voluntary for the member states to share health data. So member states can start sharing health data from their citizens, but the pace of that exchange has been very slow. It started at 2008 with a pilot project, and I think it's 2018 or so the first countries went live. And there's around 10 countries exchanging documents, but it's quite little that they are exchanging. The new proposal will make that mandatory, so each EU country will need to be able to exchange patient summaries, e-prescriptions, lab results, imaging data, hospital discharge letters from one country to another. So I think it's similar what we had in the telecommunications when using mobile phone data became free in Europe. So it is a significant change for there. Regarding the secondary use, I think it's also for the first time it defines what is the secondary use of health data in EU. It defines for what purposes you can get data, what data you can access, how you access the data, how you request permits, how do you place the data in the secure processing environments, and so forth. So I think we will have a lot of new use for health data for research and decision-making purposes. And I think it will be a game changer in both the primary and the secondary use.
Okay, so that's pretty clear, an affirmative answer, I would say. And Mario, would you agree yourself with what Marcus just said in short words?
Yeah, no, of course I do agree. So I'm speaking, of course, mostly around the secondary use of health data, but in that context, I think if we place ourselves in the context of being a researcher who wants to carry out either a project at national level or at EU level, today it is really, really difficult to conduct such studies because the times to access the data and the process to get there are so long and so complicated that there's just much more reasons not to do it than to do it. And I think the proposal, as I outlined during my presentation, through a number of leverages can address some of these barriers. So be it the times to access data, clear rules around data permits, data access processes, clear indications around what data is available through the EU-wide datasets catalog, etc., etc. So I think from the perspective of a researcher, innovator, the proposal will just remove some of the barriers and that way lead to increased secondary use and that way hopefully contribute to better health for patients in the long run.
Okay, yeah, thank you, Mario. And I will continue with you, Mario, because I had this question after your presentation. You explained a bit the legislative framework, the existing legislative framework, and the ambition of the European Health Data Space. And what is the need for a specific regulatory framework at a European level? I mean, there is already the GDPR, there is a proposed Data Governance Act, the Data Act, the NIS directive. So it can be a bit complex and complicated for the stakeholders in the field. What do you think it will be a simplification for the practitioners or the researchers or even the patients at the European level, the European Health Data Space?
So you're right. There's a number of regulations in the area, and I think Marcus had a nice slide at the beginning outlining how they came on over time. So we've got both cross-sectoral, so also called vertical, horizontal frameworks, which are the GDPR, but also the Data Governance Act and the proposed Data Act. So they create a general framework, but then GDPR, for instance, left a lot of room for implementation to member states. So the implementation actually is quite different across member states, which leads to a fragmentation of the rules across the different member states. So the process to access health data in France is not the same as the process in Finland and not the same as in all the other EU countries. So that way, yes, there's a fragmentation which keeps researchers at the European level from accessing or from more easily accessing the data. So in that sense, specific rules within the health sector around the implementation of the GDPR are interesting to resolve that fragmentation. And yes, so from a legislative point of view, it might seem more complex, But I think for the, as just described before, for the perspective from a researcher, in the end, the rules from the specific European health data space legislation are meant to make it clearer on how some of the more horizontal pieces apply for the health sector. And so I think for the end usage, it should make it easier, even though for all of the actors, the institutional actors, it might be, of course, a lot of legislative action to follow.
Yeah, but because I think it's a huge concern for many stakeholders, so it's important that we talk about this question. Ines, for instance, in the implementation of the Plan France Médecine Genomic, there is a change uncertainty in the regulatory aspect, so it can be also difficult for you to implement infrastructures. You always have to be careful on what has been created new in terms of regulation. And to be honest with you, when we started to hold this conference, we didn't know what would be exactly the content of the proposal of this Commission on the European Health Data Space, because it has been published on the 3rd of May. So of course there will be a talk and change on this proposal, but we didn't know that omics data would be included in this proposal. So that was really great for us at Genopole, and of course for the participant, because there is a lot to talk about, and that's why I want to, before we go more into details on the institutional aspects of the European Health Data Space, I want to remain the importance really of the omics data in the today personalized medicine, in today medicine, and for the future of healthcare in Europe. So on that, I will get back to the specialist of those aspects with Andres. And Andres, with the question, can you, in some words for the audience, explain how crucial it is to really to have a regulatory framework for the omics and for the sharing of the data at the European level?
No, it's absolutely crucial. Because, you know, genomics data are also absolutely crucial for health. You know, genomics, we can't really deny that. Who is telling that our environment is more important? True, but you can't get rid of your genomes. And but the problem, or let's say the facilitation what came with this regulation is that people, doctors, you know, hospitals, were really kind of reluctant to share the data for many reasons. And final reason always was that, oh, our patients don't like it, and we have to responsibility, confidentiality, and so on and so forth. But now there is a regulation we have to share, because in order to improve, we have to share. And this is simple like this, you know. And now these arguments that we really are not allowed, now there is a framework how to do it responsible way. And I guess this is absolutely crucial and makes things, you know, allows things to advance.
Yeah, it's pretty clear. Thank you. It was hard to summarize it in some words, but I think you all understand the stakes behind the sharing of omics data at the European level. And for that, I will get back to Ines. So you are the last one really to speak. No, but I think it's important that you explain what was behind the Plan France Genomic, what was really the ambition, why France, not suddenly, because it's been a long-standing plan, but why is it so important for a country like France to first develop its own infrastructure, but then to share it at the European level?
So the idea at the beginning was always, and I think it will always be, to benefit the patient with a more personalized medicine, which Andres already talked about. And I guess we all have the same ambition, at least at European level. And in order to do so, you face a lot of challenges. That's what you want me to
the challenges, maybe we can talk about the ambition. We can. The challenges, so, it will be long to talk about the challenges right now.
But I guess, actually, the challenges we face at the European level, it's the same you face at the national level, and I guess it's the same story for each country. But the idea was, in order to benefit the patients and have a better healthcare system, we need sequencing. You need the knowledge of the genome for the doctors that can better treat the patients, for the researchers to advance in discoveries and be able to predict more diseases, etc. I can go on and go on with all the I think everyone in the room already knows what's the point. And so the idea is just if at the national level you can put everyone in the same boat, let's say, with the same ambition, with the same goals, in an interoperable way and working for the same goal, then it would be easier to get along, to collaborate with other countries and make it at the European level and then international level. The idea is always the patient, I guess, the citizen, let's say.
Whether in your institution, do you have some example of bilateral cooperation with other countries, for instance?
Yes.
What are you trying to set?
So we are observers in the 1 Million Genome Initiative, but really very, very active observers. I know. I go, so I know. So it's just a matter of, French government has been through a lot of processes of changing and COVID, and so it's just a matter of signature, I guess, because we support this initiative, and we think it's very important to develop, from the start to the bedside of the patient together in terms of data standards, technology, interoperability of data to be able to share knowledge. That's where these type of projects can be rich for the advancements of research and diagnosis and medicine and etc. And so we are in the 1 million genomes, even though if it's not official, and we are also simultaneously developing collaborations with Genomics England, so the English initiative, with the Danish National Genome Center, and with the Genomic Medicine Sweden. So these are the official ones, but then we are discussing with other countries.
Yeah, certainly. Okay, so now that you raised this question right before, but you are facing, I think, some technical difficulties. Of course, it will be long to talk about all those aspects. We'll maybe focus on the regulatory aspects. If I go to you, Andres, for instance, what did you started to create this genome biobank, and then you extended, you were involved in the 1 million project. What were the main barriers you faced first when you started to build these initiatives?
Main barrier was resistance of medical faculty of Tartu University. Because they just didn't like it, because it didn't came out of, I'm a medical doctor, I graduated from this, but I was not working in medical faculty, but they were too conservative. They didn't want to do molecular biology, they didn't want to do molecular genetics. So finally, I was recruited to run the molecular diagnostic center, just to start newborn screening and DNA diagnostics. So it took many years, and only now, 20 years after biobanks, they really collaborating and started the hospital personal medicine and starts a clinical biobank. So medical professionals are moving slowly. Primary care providers were much more enthusiastic, I would say. People were enthusiastic. People, of course, there are always few who are against it, making career being against, but I was really a little bit disappointed that and opinion leaders from medical faculty didn't support it from the day number one. But you need the champions, like you mentioned, Genome England. They sequence 100,000, they had a project 100,000 genome. If they did it, they, of course, they had lots of problems, but finally lots of people understood this is what can be done. Now they are going to sequence newborns. They start doing it, sequencing first 2,000 first, and then everybody else starting to do the sequencing with newborns. So we need, I would say, the brave people who are moving ahead, whatever it takes. And then lots of people are following the suit. So I would say legal issues were probably smartest thing we did with Janos was we prepared the law, Human Gene Research Act. And it was like 13 pages, and 2/3 of it was how to protect the people. And so it gave people kind of a security that nothing bad happens. So police cannot get the data, say, insurance don't get the data, employers don't get the data, and they control the data. And if they ask now whatever data we have, if they ask them, we have to give them, and they go to the startup who's running the diagnostic or risk profile, and they can use that data. They don't have to jump it again. So I would say it was quite difficult. It was a massive PR campaign in order to win people over, because just to get 20% of population, and we recruited in the second phase 150,000 people in 2 years. So it's people really supported what we do, but
yeah, it was.
And you have to get the political support also, because you have to get some money also.
Exactly, it was also really early, 20 years ago, as you said. So everything was not, I think, settled, and the challenges were not as well known as today.
Main argument was that why we are going to do it, because nobody else is doing it. But there was a UK biobank already.
Yeah, exactly. Maybe I will get back to Marcus. Since you have achieved THDAS, I think the project has been it will finish this year, right?
No, we will finish next year in August.
Oh, my bad.
2023.
My bad. But anyway, you had maybe some. What was the key of success of THDAS? Because it's a reference, and we can consider that it is a success. You have been able to implement a strategy. You have been able to consult different stakeholders and to federate European views to go toward this European health data space. So a lot have been accomplished already. And my question to you is, what lessons have you learned in terms of to ensure the success of such initiative? And I'm thinking about with Mario right next to you, because Mario, we hope that you will be in charge of implementing the pilot. But broadly speaking, Marcus, what would be the key of success to ensure a European collaboration between so many countries?
All right. I think the key for the success is, of course, we have a common mission, and we understand our role. I think it's very crucial in the beginning to explain to our own people in the Tehdas joint action that we are not the decision-making body in the EU. Also that we are not piloting anything, we are not implementing, we are not building any infrastructures. We are there to help the member state and the Commission in making those right decisions regarding the European health data space, and helping the Commission in preparing the proposal. So we understood our role, and from that perspective, we came into the discussions, and member states who participated there, because they understood that we are there to help. We are not the decision-making body. So I think the partners were not that keen to kind of like find their own way or promoting their own ideas, but to come together and to promote secondary use and to give options for the member state and the Commission. So I think that was one of the first things that we tried to highlight, to understand the role of our project. I think the second learning from our project is to involve the stakeholders. The first thing we did in the beginning of the project, we started an open call for stakeholders to participate in the advisory boards of our work packages. So the work packages have advisory boards which have stakeholders from the industry, from patient organizations, from research groups, and so forth. We have also participated in different advisory boards of the European Medical Agency. We have been involved in a lot of different activities. I calculated that 1/3 of our budget goes into external activities, and such as this event today. So I'm here speaking to you because I want to collaborate with you. So it is this kind of perspective that we have for the collaboration. Also, many of the work packages started their work by analyzing what has been done before. As I said, we analyzed different legal proposals. We analyzed what is done in horizontal, why health is a specific case. We didn't take it for granted that there's a need for new regulation. We didn't take for granted that there's a need for new architecture for the secondary use. We analyzed the existings, and then we built from that. And we involved the stakeholders. We understood our role. I think those kind of lessons learned could you pick from the Tehdas joint action.
Okay, so we all should consider those advices if we want to implement a global scale initiative such as this one. And For that, I will maybe get back to you, Ines. So you are in the process of implementing this connection between sequencing platforms at national level. And my question to you is that what challenges are you currently facing?
So
the priority, what?
Okay. I guess it should. I can start by interoperability. I know.
Yeah.
I cannot say this word. In terms of all the steps of the, let's say, the chain we are trying to build in France. So in terms of, you know, data and the way you move around after sequencing the patient, let's say, and it has to do a long way in order to have the results being analyzed, go back to the doctor, and then go back to the patient as a result. So these are a lot of different steps that need to be more, let's say, now they are working, but we faced a lot of technical and kind of sometimes legal, ethical issues. So I guess this is the same, as I said in the beginning, that these are the type of challenges you have at the national level that will be times, I don't know how much, 100, 1,000?
Yeah, 100 times for at the urban level, that's
yeah.
what you say.
How many countries you can add up to the equation. So there is the ethical framework, there is the legal framework, I guess, and there is also, if I can put that in the European level, let's say, not every country is at the same state of development of this type of initiatives. So I guess that I agree with everything that Marcus just said before, but I guess it should be included in this type of projects, and I guess 1 million genomes is already, it's an initiative that's already trying to do that, to help all countries to get to the same level of let's say, ambition and realization, to avoid competition, and so that we can always discuss as experts and medical doctors and everyone that is included in this type of initiatives can be able to discuss at the same level of advancements, and all the patients will benefit in the same way. So I guess this was something I wanted to add to what Marcus said.
Okay, but what comes in mind after what just you said, it's, I mean, if I am from a country which is not really advanced in terms of development of infrastructures, I would see EHDS as a huge challenge. A huge challenge, because I have not been able to develop it at the national level.
That's why I say. So that's what I say, that in some it's a great project, but I guess it should be included, let's say, in the mind of the European Commission, if I can put it this way, that some countries needs a little more effort, or a little more help, or a little more discussion, or a little more financing, and we can go through this the whole day in order to reach this level. But this should be kept in mind in this type of projects, and it's something that is already done in the 1 million genome initiative, because there is a lot of discussion, there is a lot of sharing. So that's the thing. What is more rich about 1 million genome initiative is that people go and discuss in a very open way of what is happening on their own countries, and that's when the first collaboration the French initiative made was with Genomic England, which was the first European country in launching this type of mass sequencing for research, and we learned a lot with them. There was a lot of sharing of mistakes that they have made, so that helped us go faster. And we made mistakes. We always make mistakes, but not the same ones, so that other people can profit from them. So this is already, let's say, a space, the 1 million genome, where countries can discuss and try to move faster, because they can learn from other people's mistakes and think of different strategies. But then you have all the other aspects, so financing, interoperability, how, legal framework, because each country has different way of governance, so they face different challenges. different ways of being, regional levels
Of course, you may.
You know, most of the time goes national discussions between different stakeholders. If there are rules and models to adapt, to find the money, to find the people, it's 10 times easy to get to the same level. But just to develop something, it's really time consuming. And if there are rules set, it's, I would say, easy to adopt them. Takes few effort, but still you can do it and much faster.
Yeah, you're right. The time is running, but I have a question that comes into my mind when I hear what you just said. We are talking about a certain type of data, omics data, with the 1 million plus genome project, with the Plan France Médecine Genomic. EHDS has the ambition to framework different type of data. And I will get back to Mario. I will put you under the spot, Mario. I'm sorry, but I will be a bit provocative with this question. But can we say that the EHDS proposal is a bit too ambitious?
Too ambitious to achieve what? I guess, I mean, the question on you can look at every article in the proposal and say this might make it more difficult or challenging, more ambitious or less ambitious. I think for that reason, also the countries and the parliaments, or the council and the parliament, will continue to discuss and interact with stakeholders to make sure that the final version of the proposal is achievable in a certain extent. And if there's certain pieces that in the end will drop out, they will drop out. But I think, generally speaking, even if an ambition is high, it doesn't mean that everything is achieved from day one of implementation of the text. So there's a framework that will require a lot of work from different actors, and we hope to contribute to that with the EHDS pilot if we are successful, in which case we would also look at, and TEDAS is already looking at it from a more general perspective, but what individual countries are still lacking, or what countries need to do to get to a level they need to be within the context of the European health data space. So I think those projects are aiming to make sure that countries and different actors can get up to speed with what might be required from them under the EHDS. And then, well, the final ambition, it's not for us to define where it should be. We are, of course, happy if the ambition in the context of secondary use of health data is high, because we think it's a very important topic. But yeah, then it's not us who set the ambition. So I think high-level ambition is rather healthy.
Okay. Well, Mario, I think you summarized it perfectly. The ambition is needed to help countries and to spin off together. I think it will be the end of the panel of this panel discussion. But maybe you can say a couple of words, each of you, regarding this proposal, which is relatively new. Do you have some key aspects you want to emphasize before we leave, and maybe some key messages to the audience, maybe to help them grasp this initiative better and understand what could be, if we could be optimistic about the future of healthcare in Europe. So maybe Ines, I will start with you, your left.
Okay, so I guess if I have a take-home message to give, it would be we move forward faster, and we are better in this type of context of personalized medicine if we are together and not alone. So this is true at the national level, at the European level, at the international level, let's say. So takes a lot of, it's time consuming, it takes a lot of challenges to face, but as you just said before, problems are there to be solved. It takes a lot of ambition, and so I guess you can go step by step, national level, European level, different types of clouds, let's say, with health data to at some point in the future move forward faster and benefit the patient. I guess the main idea is that for me it's never too ambitious, because the benefit will be to the patient, to the citizen. So every means you can put together to help advance research, diagnose healthcare, it should be done, even if it takes longer for a few countries than the others. But at some point we'll meet, we'll be all at the same state. So
yeah. Confident. Thank you. Andres, maybe?
I think that we have enough data and regulation and secure data handling for professional societies to move on and put this genomics for prevention into treatment guides. Because without this, nothing happens. So all doctors are looking what this recommendation comes from European Society of Cardiology or European Society of Oncology or whatever. Now, I understood that probably later this year, US professional societies are starting putting PRS into the treatment guides. UK will follow, and finally the continent has to follow. So I guess now we have to really go into the real medicine and real, I would say, personalized prevention.
Okay. Marcus?
Well, I agree with what has been said. I would like to finish actually with a call for action for everybody who's listening. I think we would need to, I mean, you are all basically decision makers or influencers in your own sphere. And I think it's important that we talk about the urban health data space. We talk about 1 million genomes. We talk about the primary prevention with genomics, all the things that you have heard today. And I think we need to make this kind of communication loud and clear for our decision makers, also in the ministries, in our member states, that this is needed. I think without the support from stakeholders, it might be that the EHDS will sound too ambitious. But if they hear the message coming, common message from all of us, that we really want to progress as a Europe, then I think this is doable. So it's a more call for action for you than a new message from my side. Thanks.
Thank you, Marcus. Thank you. And finally, Mario, the last but not the least, as we say.
Yeah, thanks. I would like to echo what Marcus just said. I think it's really important that we talk about it and that everyone here gets involved. I think we all have something to say around the matter, and can be both positive and negative around certain aspects, of course. So please get involved, and yeah, also be reminded, of course, in the European context, if there's countries, for instance, that are more advanced than others, there's also mechanisms to help each other, hopefully. So I think we can learn from each other. And so, for instance, of course, Finland has been very early, very advanced. So we have been happy to learn a lot from them also. So I think that we should keep in mind that the European framework gives us also the chance to learn. And yeah, thanks.
Okay, so I think I will end the panel discussion, or we can continue hours and hours. I think it's really long as a discussion, really broad, but I think it was important, and you all, I really want to thank you for your participation, for your organization also, to let you come to our event. I think you helped the audience to get more information about the EHDS ambition, which can be really difficult to grasp on some aspects, and we hope that we can continue to work with you. I think we can contact you also. You have shared your email address, and if people have questions or want to start even a partnership with your different organization, can be interesting to contact them directly. We'll share the mailing or the contact address. So thank you very much, and we should have a break now, so I think it will be a shorter break because we talk too much, And I tell you just in 5 minutes top, we can start with the second session, which will be more focusing on practical case related to the health data. Thank you very much. Welcome back, everybody. Thank you for coming back to us, and I hope you enjoy your little break. I know it was rather short, but we have a lot of things to discuss along this morning, so I think it's more important that we go directly to the interesting presentation we have in this second session and third session. So this second session will be more about the practical views from professional. We'll have, as I said, the AFM Téléthon. We'll discuss about the use of secondary use of data for research purpose. Then we'll have a perspective from the hospital with the Charles Vestegem, so the accessibility and interoperability of health data in Denmark for research and clinical practices. And finally, we will finish with Biome, an incubator of digital startups in the field. So those perspectives will be summarized and discussed then during a panel discussion later at the end of the second session. So without any further delay, I will start now with Adrien. Adrien, thank you for joining us. Yep.
Thank you.
So Adrien, if you can introduce yourself, your organization, and the floor is yours.
Yes,
thank you very much.
So firstly, I would like to thank the organizers for allowing me to speak here. And so I'm Adrien Delattre. I'm a bioinformatician at AFM Téléthon. And in this presentation, I'm going to talk about the different database projects that we are undertaking as an association. So firstly, for a little bit of history, the AFM Téléthon was founded in 1958 by Yolande de Kepper, which was the mother of 7 children, among which 4 of them had Duchenne myopathy. So she founded the AFM Téléthon, and this was initially an association purposed at providing support to patients suffering from Duchenne myopathy and also their family. And this goal was extended a bit when in 1986 the gene responsible for Duchenne myopathy was discovered. So this sparked the hope for treatment, and shortly after the first French Téléthon.
Elle est où, Mathilde?
Okay, so yeah, in 1987, the first French Téléthon was started. So this is a yearly fundraising event made in order to collect money to support the association and also to foster research on neuromuscular diseases in general, not just Duchenne myopathy. So we're a patient and patients' parents association. We are purposed at providing assistance to people suffering from neuromuscular diseases in general and fostering research in order to find a cure to those diseases. We're involved in research and help toward the patients. We're involved in social and scientific innovations. And it is important to highlight that while we are specifically funding researches on neuromuscular diseases, ultimately the obtained results benefit to all rare diseases, genetic diseases, and actually more frequent diseases. So why are we actually funding databases projects? This is because obviously if you want to study a disease, you have to collect a sufficiently large amount of data, that is a sufficiently large amount of patients in order to draw a conclusion. The problem when you work specifically on rare diseases is that as a clinician, if you consider only the patients that you have in a reference center, you may not have enough data to reach any conclusion. This is why usually the data from all the reference centers across a country are collected in a single database, so you can actually have enough data. So such a database can be used in multiple ways. For example, you could use the data that you already have inside your database in order, for example, to get a better understanding of the patient history. Or you can also use the fact that you have a list of patients plus their health data in a database in order to filter those patients according to, for example, some medical criteria to get a list of eligible patients that you can then possibly enroll for a clinical trial. So in this process, I'm the guy with the blue jacket in the middle, so I interact with all... Yes, I did it on purpose. And so...
You are not yellow, your skin is not yellow though.
Yes. So I interact with all the different people who are involved in this change from collection of data to the production of results. So I interact with the CRA, which are the clinical research associates in green, who are the people who collect the data from where it is stored at the hospitals into the database. I interact with the clinicians, which can occupy multiple roles in a database project. For example, they can be project leaders, they can be data providers, they can be analysts, they can be curators. I interact, of course, with jurists and system security experts and external service providers, because jurists and system security experts have requirements about how the database should be organized, its architecture, etc. So they may have also sometimes conflicting requirements. So I have to be the person actually making some sort of compromises and writing the specifications to the external service provider, who usually handle most of the technical parts, the technical aspects of the implementation of the database, such as data storage and the backend. I also work in partnership with data analysts, because I have to make sure that the data which is stored in the database is stored in a way which is actually workable in order to do statistical analysis on them. Because the requirements of the data analysts are different from the requirements of the clinicians. So the data has to be workable for them. I also interact with the patients mostly through patients' associations, because at FM Territory we believe that patients should be an actor in this process. So yeah, just to list a few examples of design constraints that must be implemented into health databases. I have, for example, to determine the different roles that can connect to the database, what kind of actions they can do. For example, you have to avoid phenomena like, for example, privilege escalations and things like this. And also have to design the different, what we call the data workflow in the database, because data, once it is entered into the database, is not inert. This is something that can have multiple validation status. For example, when it's firstly entered by the CRA, it's not validated, but then you have to make sure that the system is designed in a way such that the proper curator is notified that they have to validate the data. Once it's done, the data is then validated, but if it is further modified, then depending on the person modifying the data, it may get unvalidated or stay validated, so you have to work all the things out. And also another kind of constraint is that now data must be pseudonymized in order to be stored in databases, so the database has to be organized in a way such that it is possible to re-identify patients in some very specific situations, but not in any other situation. So just to present a few database projects which are currently funded by the AFM Téléthon. This is just a few of them, because the list is actually very long, but for example, we have the French Dystrophinopathies Registry, we have the French Observatory of Myotonic Dystrophies, which is the MSCOPE, we have the French Observatory of FSH, and there is actually an ongoing project to federate the different databases under a single portal, which would act as a single entry point. For the moment, all those different databases have been developed in isolation, but in the future, so we try to develop that portal, so we will actually be able to do new things, like, for example, transverse databases. Because, for example, for the moment, they are all disease-oriented, like you have one disease for one specific disease, but what if we want to make a database about a specific aspect of multiple different diseases, like cardiomyopathies, for example. So this is what we want to do, and this is why we are trying to do this single entry point. In terms of governance, All the different database projects have their own steering committees, which is made of clinicians, scientists, and patients' representatives, because we try to involve the patients as much as we can. So, for example, they are involved in item choices in the different forms, and also in documents proofreading. As we have seen, it is beneficial to the study of rare diseases to mutualize the data, and we can actually extend further this logic. Those databases have already been done in multiple different European countries. So extending even further the mutualization across Europe is actually the aim of the European Reference Network for Neuromuscular Diseases. So what they try to do is not to centralize all the patients' data into one single database, but rather to build a sort of registry hub through which the data of the different national databases could be accessed. Of course, in order to reach that aim, it is necessary that the data in the different national databases comply to some sort of standard. And that standard would be the FAIR model, which stands for findable, accessible, interoperable, and reusable. This implies notably to have rich metadata to describe the data, to have persistent identifiers, and a common set of items between databases, which have been decided by a joint research committee. And also, it requires to build an access policy for data inside the databases, so the owners of the different databases keep control over who they share the data with. So, as a conclusion, so at IFM Téléthon, we collect and valorize health data scientifically and politically through both the promotion of medical research projects, the creation of disease-specific and possibly transverse databases. And this role in the current ecosystem is essential and complementary of other industrial and academic projects. So we are a consultative, contributive. So we have a consultative, contributive, and productive role. So thanks for your attention.
Thank you very much, Adrien, for your presentation. I think it was really important to refocus on a concrete example of what is it exactly, how to structure a database, especially when you are dealing with rare diseases. So, but my question to you is that you followed the panel discussion we had previously, and so the importance of structurating and the fair access at European level is really important. You have some example of collaboration with the countries currently at the IFM Téléthon?
Yes, but this is really a work in progress. Like I mentioned, one database, which is DM Scope. So this specific database is will be involved in the verification project, and it will its data will in the future be accessible through the registry hub for neuromuscular diseases. But since this is a work in progress, we're still working on the process of what we call verification itself.
Because the challenge is huge for especially for rare disease to be able to access other data, since it's rare, rare data obviously. So it's really important. There is a huge challenge to access different data set in other countries. So I think the European Health Data Space is somehow will benefit from those collaboration and will improve tremendously the work you are already conducting at the IFM Téléthon here in Genopole. Thank you very much, Adrien, and hope to see you later to discuss more deeply into this subject. So the next panelist will be online. So I would like to welcome Charles Vestingham. Charles, are you with us?
It should be, yes.
Oh,
hello,
thank you,
everyone.
Thank you, Charles. We can hear you very well. Thank you, Charles, for being with us today. I don't know if you have been following the previous discussion. If it was interesting,
yes.
if you can bring something to complete what has already been discussed, maybe in a more, I would say, clinical aspect of the management of the data. So Charles, I will not be really long. I will let you introduce yourself, your activities, and then you can start, of course, your presentation. Thank you very much, Charles, for being with us.
My pleasure. So yeah, thank you for having me. So I'm Charles again. I work in Denmark at the Department of Hematology, and I'm working mostly with health data solutions and also AI-based decision support tools. So it's a lot of infrastructure, and so it's, I think, really relevant for the European health data space. So yes, I'm going to share my screen so you can actually see. Can you see it? Okay, great. Good. So I'm going to talk about the case of Denmark, which I think is very most probably the most advanced country in terms of digitization in Europe. So I think it's going to be a good reference in terms of what can be achieved. And I'm going to talk. Sorry, my bad. I'm going to talk specifically about interoperability and accessibility of the health data. So Denmark, it's a rather small country in Europe. It's less than 6 million people. It's roughly the size of the Occitania region in France, just for the perspective. It's split into 5 regions, and the region's main responsibility of regions is to take care of hospital systems, so healthcare systems. It's public funded healthcare system, as most countries in Europe, actually. And there is a very high level of digitization. It's actually the first country for some kind of ranking called DESI 2021. There is a few things to know about Denmark. One of the main thing is there is Danish, there is national registration number called CPR number in Denmark. And it's used for all interactions with the administration. So seeing doctors, paying tax, getting support for kids, everything. Your banks also use this number, which makes it actually extremely easy to link all data sets, health data set, but also administrative data sets across Denmark. And of course, it also covers the whole population. So it's, even if you're not a Danish citizen, you still get, as long as you live in Denmark, you will get the CPR number. And so just here is a small example of all the data sets that can be linked, through the CPR. Is basically everything from birth to death. So it gives tremendous possibilities in terms of data integration. So, but of course, it's not just. Not everything works. For example, primary use, it doesn't work very well. So each region, so we have 5 regions, have their own electronic health record systems, and they are not accessible to other regions. Also, GPs, so general practitioners, have also their own electronic health record system, which are not accessible to other clinicians. And then, of course, patient journals are mostly text-based, and so it's Danish. Which makes very limited accessibility and interoperability if we think about the European scale, because I'm guessing a French doctor will have some difficulties reading some Danish. But of course there is some hope for the primary use of health data. Some regions use the same provider, which kind of should make it easier to get access to each systems. There is also some push to support some data sharing standards, such as FHIR standard. And of course, there is some national infrastructures that are being put in place. For example, the National Genome Center, which was mentioned earlier, where sequencing will be done in one place in Denmark, and the data centralized there. So now let's look where it works. So it's secondary use, mostly research. So Denmark is at the forefront of epidemiological research. There is centralized collection of health data at the national levels for health data, administrative data, but also quality data, for example, following cancer, survival of cancer patients and so forth. It covers the whole population over a long period. And as I was mentioning earlier, all the data sets are easily linkable through the CPR number. And there are a large variety of numbers. So here's just some examples of where you could find the data. So you have biobank, statistics about social conditions, hospitalizations, genome information. So a lot of information that can be easily coupled and over a very long time period. So just as an example, let's talk about major data set which is used in epidemiological studies in Denmark. It's called the DNPR, the Danish National Patient Register, which contains information, data about all hospital contacts for patients. And since almost all patients, actually, or even private hospitals actually have to feed into the system. And so it contains information about diagnosis, procedures, and treatment, of course, done at the hospital. Well, it's actually an administrative data collection system, so it's for reimbursements. But overall, there is very high quality of the data which is collected, so it's been used widely in research. And of course, not of course, but actually luckily it's based on coding standards, which makes it very easy to kind of compare data globally. So it's like the ICD-10 for diagnosis or ATC for drugs. So there is very good interoperability for the data sets. But of course, there is some challenges. It's not just like the data is freely accessible for everyone. So there is a rather long process in order to get access to data. So there is ethical committee review, which is of course completely necessary. But it's not just like everything is really available. But there is a process in place which works well, but can be a bit time consuming. So how is Denmark an example for the European health data space? Denmark has already a very highly digitized health data. There is this CPR number, unique identifier, which makes it very easy to link data sets, which I think is kind of a challenge for most countries. I guess Sweden and I think the Nordic countries typically also have this type of numbers, but I know in France, for example, it's much more challenging. We definitely need some European coding standards for interoperability because if people are not using the same code, it's going to be complicated to kind of compare the data. Then what's also very practical in Denmark is like the centralized ethical approval and also the availability of very good infrastructure, which if you have to ask 1 million different ethical committees to get access to data, that's going to basically stop most of the projects in the egg. And there is still some challenges, of course, notably with primary use, as I was mentioning a bit earlier, where it's very difficult to actually, if you're not within the region, to actually get information about the patients, and this problem also of language with the Danish. So that was just a very quick overview of Denmark. There is actually a campaign going on right now from the Health Data Authority in Denmark, which is kind of trying to promote Denmark as a very good place to, which it is, to make epidemiological studies, also to kind of bring, companies to invest in Denmark in the field of health data science. So that's definitely there is a strong push there and a very strong will to actually make it work as much as possible. So that was my take on the Danish case, and so I'd be happy to answer your questions if you have any. Thank you.
Thank you, Charles. Thank you, Charles. It was really nice to have an example from Denmark. But maybe you can stay a bit longer with me if you want, because I have some.
Yes.
I have a global
Pleasure.
question. So Denmark, you say, could be an example for the EHDS on the EHDS perspective, except on there is two points, challenging points. You are talking about the primary access.
Yes.
Primary data access. Yeah.
So what I meant was, it's more, if you're a clinician and you have a patient which is coming from another region, it's going to be extremely challenging to actually get any kind of information about this patient, from electronic health record system from another region. So it's actually easier to get information through the the national registers and actually trying to get the data from the other region. I talked with some clinicians where they basically say that they have to print the electronic health records and send them by mail to the other hospital. So it's really right now it's not working well, and I think it's going to be it's also going to be extremely challenging for in a European context. Let's say you're German. Let's say you have a patient who live close to the border from Germany, and they want to get treated in a German hospital because they have better treatment availability or something like that. Then it's going to be extremely difficult to get the data out of Denmark for this, and actually for the German clinicians to be able to read just the record of the patients.
So, do you feel there is any concern from stakeholders of Denmark on the implementation of the EHDS at the national level in Denmark? I mean, it's relatively new, of course, but have you already discussed with some of your colleagues or some of the stakeholders from the state at the regional level, if there is any plan at the Danish level to be aligned with the requirement from the EHDS potentially and from the European regulation in general?
I know there is strong, there is some work going on actually. I think it's Danish Life Science Cluster, which is working precisely on this subject of EHDS. Kind of what should be done in Denmark to actually align perfectly with the requirements and the specification of the EHDS. Yes, but I'm not personally involved in that part.
Okay. Well, that's okay. We'll have some time to discuss this later, I think. Okay, thank you very much, Charles. Thank you very much. It was really
You're welcome, my pleasure.
And thank you for your time. Of course, if you want to contact Charles for different reasons, or if you have any question, I don't know, Charles, is it possible to mail directly to you or from the audience?
With pleasure.
Oh, okay.
Just don't hesitate.
Okay. So we will make sure that we will forward this exception. Thank you, Charles, and see you later. And have a nice day of work, I guess.
Thank you. Bye-bye.
Thank you very much. So now we had a perspective from the research. We had a perspective from the hospital. And finally, we'll have a perspective from the entrepreneurship. So I welcome Timothée. Timothée, are you with us?
Yep, I am here.
Okay, thank you.
Can you hear me properly?
We can hear you well.
Perfect.
Okay, perfect. So Timothée, as the other previous speakers, I don't know if you followed the previous discussion and if it was of any interest for you.
It was super interesting. Thanks a lot, and thanks again for inviting me. And indeed, I think I am the first speaker giving like the industry perspective, and hopefully it will be complementary to what you get before. Can you confirm me? I have still 15 minutes since.
You have 15 minutes. Yeah. You have. We are running late, but you have 15 minutes indeed. Okay. So let's start and good luck.
Thanks a lot. So I will give a perspective at the bridge of indeed entrepreneurship, but as well with the big pharmaceutical company perspective. Since I am working within the biome, which is a department at the interface of entrepreneurs, but more broadly at the interface of the healthcare system and Novartis Associates. Just to give you a slight reminder on what Novartis is. So it's a quite large company operating in multiple countries, especially across Europe. And we have a broad range of disease we are covering as well, including oncology, neuroscience, cardiovascular disease, ophthalmology, immunology. So it's very broad in terms of countries, in terms of patients that are treated with Novartis treatment. And also we are deeply involved in innovation. It's not a new topic for Novartis, but when it comes to digital innovation, it's quite new. It's quite new to use innovative solution to analyze data. We are obviously generating real-world data and real-world evidences for years, but now we are entering into a new area in terms of technologies and in terms of type of data. And we needed this entity, which is the biome, to being able to catalyze interaction with the healthcare system, with data provider, with innovative tech and data science startup, which are developing new technologies to query, to anonymize, to analyze real-world data to generate real-world evidences for multiple purposes. So we are at the interface of this very large ecosystem and Novartis Associates across multiple countries and multiple therapeutic areas. So the first point, and I think it's super important when it comes to the European data space, is to break silos. And that's what Biome is doing. It's breaking silos across people and across innovation. And notably to avoid any kind of competition between countries, to avoid multiplication of efforts, where there is value to join capabilities, tools, data sets for the end goal, and there is multiple end goals we are interested in at Novartis. So again, we are helping both Novartis Associates and external ecosystem to get a better understanding on challenges. There is a lot of people sometimes are wondering actually what is actually interesting in terms of data for pharmaceutical companies. So we are trying to explain to the ecosystem what is actually interesting for us. And in the Biome operating model, I will skip the four first step, which is basically the way we are identifying problem statement we are working on, what will be the main issues that are actually interesting for healthcare professionals, for patients, along with Novartis. We are identifying partners across Europe. We are cross-border, so if the best technologies or the best data set is actually not in France, I am mainly on my side operating in France, but actually if the best innovation is outside of our border, we will look at that. And finally, the last step is scaling. Like, how can we scale the innovation starting in France or starting in other countries, scale it to Europe and even at global perspective. So I am working within the Biome Paris, but actually there is almost 15 Biome operating at global level and 5 Biome operating actually in Europe. And we are really connected together to share expertise, to share tools, to share potential partners, to share ideas and potential data sets that will be relevant for a specific need. And it's super important. It's a core value, which is super effective, being able to break against silos between countries, but also between therapeutic areas. And I think it's super important to share also expertise between different therapeutic areas. In some instance, in oncology, there is it's quite mature ecosystem compared to other therapeutic areas, and there is a lot to learn and cross-fertilize between therapeutic areas. I would like to enter into more specific details on few concrete examples of what could be an opportunity for us to have this European common data space. The first one is and we are not mentioning usually this example, but actually there is tremendous volume of data that are generated by pharmaceutical industries across Europe, but also at global scale. And there is a huge opportunity to leverage this retrospective data sets that are generated notably within the scope of clinical trial, to generate new insights. And being able to not working only at the French level, obviously most of clinical trials are done at least at European level. There is a huge opportunity for us. We are developing infrastructure at Novartis. We have internal data science capabilities to generate infrastructure, but being able at some point to merge or to associate with a broader data set at European scale will be a huge opportunity, and being able to give access to external stakeholder, researchers, startup, to generate new insight on this data will be extremely valuable. The second point is how can we leverage external data for the purpose of research and development of new innovative medicine. So there is new opportunities with innovative data science technologies to foster development, notably, for example, within the scope of clinical trial. When it comes to clinical trial, we have to do feasibility studies. We have to evaluate what will be the most suitable countries to open the clinical trial, where there is the most chance of success to identify patients, which is highly challenging, especially, for example, for rare disease, where there is a very few number of patients. So when it comes to identifying what would be the best healthcare organization at local level, but what would be the best country at national level, and what would be the best region at regional level, it could be a huge opportunity to leverage not only local data, which are sometimes non-representative of a very specific population, but being able to identify active cohorts, active patient data sets at European level, thanks to a common data space that are sharing obviously same kind of data set structure and the same of tools would be highly suitable. And when we compare to United States, actually, where they are more mature with this kind of feasibility studies tools, they are able to query at national level, which is somehow equivalent to European level, their whole countries with innovative tools in a very simple and homogeneous manner. We see that we are quite lagging, and we can miss opportunities to open in the most efficient ways clinical trial in Europe, and obviously it's missing of opportunities for patients in Europe. And also when it comes to research and development, ultimately there is an important matter in terms of market access to generate supportive data for our market access dossier, in addition to data that are generated in clinical trial. And for this specific point, we see there is discrepancies across Europe when it comes to expectation on what kind of data each countries have specific requests in terms of new data that will need to be generated for specifically France or other countries. And I think it's a very important point for the European data space that it's not only a technical matter, but also it's deeply linked with all challenges in terms of regulatory discrepancies and regulatory expectation, not only in the way we are accessing data, but in the way we are using and for which purpose we are using this data. And if we are not aligned on the ultimate goal, we might miss the opportunity to create the most appropriate infrastructure to leverage any kind of data that will be shared across Europe. So that's linked to innovative medicine. And the third pillar I would like to mention here is obviously digital health. Digital health, and it's digital health developed by our partners. Obviously, Biome is connecting with innovative startups, and we are deeply supporting this startup to scale across Europe. And obviously, again, if there is discrepancies in terms of data that are used for the development, along with discrepancy in terms of regulatory framework, we have a limitation in the way we are scaling across Europe. But it's also where Biome is actually providing value to being able to understand what will be the most suitable framework locally. Along with other Biome, we are able to connect and say, okay, there is a DIGA in Germany, we can connect and explain what will be the specificities in terms of data that will be specifically needed for the DIGA, or for a specific pathway in terms of reimbursement in France as well. So there is still a huge need to develop local capabilities and to break silos between countries to understand what are the common ground, but also what are the specificities, because we will always have specificities in terms of ethics, because we don't have the same perspective in terms of reusability of data. In some countries, you can expect the possibilities to explore innovation that will be not possible in another country, and not due to regulatory framework, but due to the ethics and the perspective of patients on specific innovation. And also, in terms of digital health, we are entering into a new area where we see digital therapeutics entering in-house pipeline of pharmaceutical companies. So today, we are, along with innovative medicine, we are also developing digital therapeutics, and we have we are exploring and seeing what will be the challenges and opportunities and specificities between different countries, and again, sharing common practices in terms of technical, regulatory, and the way we are partnering with the system will be super important in the future to foster the adoption of this innovation, because compared again to markets that are more homogeneous like United States, we are confronted with more challenges that have to be tackled. That's the three examples I wanted to give, and I think there is slightly more than 1 minute for question if you want.
Thank you, Timothée. You were really, indeed, really effective, really efficient, really fast. There is a lot of aspects to talk, obviously, from the industry point of view. If the audience has any question, maybe we can take one if you want. In this case, I think we can continue. And if you have any question to Timothée, don't hesitate to mail him. So maybe it could be interesting for some organization to understand a bit more about the Biome process and of scaling up the startups, and discuss it with Timothée. Timothée, again, thank you, Novartis also for your time, and we will start with the next panel discussion. It will be really interesting. I'm pretty sure for everybody. So please, can you take the seats?
Thanks a lot.
Thank you very much, Timothée. Goodbye.
Bonjour. Hello. Yes, it's working.
Okay, maybe I give you the floor, Laurent.
Okay, if you want, yeah. Okay,
I
thank
give
you,
the floor,
Alexis.
right?
Yeah, it's okay. It's okay. That's fine.
Without any preamble, without any introduction.
Yeah, go ahead with the introduction, Alexis.
No, I have nothing to say. I know that you will be able to do it yourself.
It's a new panel with 4 people. I think maybe Sandrine is online. Sandrine, yes, online. Yes, you are here. Okay, so thank you very much to everybody, and thank you to be here. I have a very, I would say, interesting panel with a lot of people that they like to talk, so it will be very, very easy for me to moderate. So I will do a quick introduction first, woman first, as it used to be. So it's Sandrine de Montgolfier, that she's a professor of epistemology and ethics she's online, as you can see. Then you have on my right Nathalie Julien from UCB Pharma, data transparency lead. On my left, Mr. Peter Villax from Portugal, CEO of Mediceus, if I remember well, and of course on my far right, it's only a direction. It's Mr. Professor Deleuze, who is the director of Centre National de Recherche en Génomique Humaine, which is a big center of sequencing based at Genopole. So let's talk about data, science, and people, which is of course very important for this topic. So I will start with a question. The first question that I know that you have a lot of things to say. And also one of these key aspects is the European data space is to foster the patient empowerment, which is, of course, it's a good question and very interesting question. So maybe we can start with you, Sandrine, if you have some word to say about, if it's the right word or not. Let's talk, and then after, all of you can react.
Yes, thank you very much to let me discuss with you. I'm sorry not to be there. So first of all, I would like to say that the terminology empowerment perhaps is not the right word to use, even if it's usual now to use it every time. Indeed, we have a lot of challenges to resolve with those data. And first of all, is the trust between patients, citizens, and us, scientific, to be sure that, and all the political also actors and so on. And if we want that citizens are engaged in the decision to let their data used by yourself, we absolutely first need to inform them on what we are going to do, perhaps how, and perhaps also after the use, what we achieved with them. And right now, we don't have all those process really implemented. So my first point of view is, firstly, before empowerment, is to develop the trust. That's the first point. We know, all of us around here, that to use data, we need consent. I think from my point of view that it is a disillusion to think that the consent solves all the problem and lets the citizen to be able to decide totally if he would like to let their data used. We know how it's going on in the care system. It's so difficult to have professionals able to explain simply and to let the people be aware on all those problems. So I say that in the majority, every one of us, we signed that we agree on the fact that all those data are going to be used, and it is a great thing, but it's not a consent from my point of view. It's not a good consent. We absolutely need to better inform. So that's what I wanted to say firstly.
Okay, yeah, thank you very much, Sandrine. So maybe somebody has to react. I know, Peter, you have some word about this kind of consent?
Absolutely. We need consent because I'm completely in agreement with Sandrine de Montgolfier. And I go even further. This is not about being or developing patient-centric systems. This is about developing citizen-centric systems. Because we need to look at healthy people even before we look at sick people. Sick people happen to be low-hanging fruit, and they're motivated to join these digital health systems. But we need to be more ambitious, and we need to start with healthy people. And there are groups of people that are desperate to join this, like mothers. Mothers want to be able to store their kids' data in a safe environment. Now, when we look at the law, and I looked at the law for 2 years, it is so clear what GDPR tells us. It needs to be person-centric, and you need to get a volunteer okay from that person. So you start with consent. And once you have consent, at least in Portugal, where the law is extremely clear on ownership, you can instruct hospitals to send all that person's data that has given consent to a central database like me. So just to put this in perspective about citizen centricity as opposed to institution-centric applications. We saw the presentation by Novartis Biome, fabulous system, institution-centric. What we're proposing to do is something that starts with the power and the consent of the citizen.
Thank you, Peter. That's very clear. So I think this is one part about consent and people and level of understanding, which is, of course, very different and according to country and according to the level of patients. That could be, of course, a good point. Maybe
yes, yeah. But GDPR is all over Europe.
Yeah, you're right.
If you follow GDPR,
right,
you do have chances of being successful pretty much everywhere.
Okay, so we have to follow GDPR. Maybe
as you know, yes, I wanted to complete. As you know, GDPR is when you work on it, it's a good technical solution. Not technical, but a good frame to work on data. So this is clear. But the problem is how to...
We don't hear you? No. We lost Sandrine. So we lost Sandrine. So, okay, okay, let's... We don't hear you anymore? Yeah. Just... So we agree with you, Sandrine, I hope, but okay. So maybe yes, we will come back to this. What Sandrine was saying. Maybe we can go to another subject. What it could be about information and data. That UCB and Nathalie are very well involved on that. So what do you think about data? You are working on clinical, so data are very important. Which kind of data do you need? Which kind of level of understanding and you need? So if you can tell us a little bit more about that.
I think, and I will back up what the other panelists say. It's a bit different. I'm working in data sharing, but I'm talking about clinical trial data sharing. So this is very different from sharing data from an entire population, because the cohorts of clinical trials are much smaller indeed, and most of the cohorts are patients. We do have some cohorts with healthy participants, but these are usually phase 1 trials, and we do not share data with phase 1 usually. So I think data sharing, when talking about clinical trial data, is a little bit easier in a way, because there is a willing to share, and also a clinical trial is based on an informed consent, which is signed by the patient. And in the informed consent, we do have a specific section for data sharing for secondary use of the data, which is collected for the purpose of the clinical trial. So I think, in a way, it's a very regulated environment, the environment of clinical trials, but that does help us for secondary use of the data and further sharing. And then we have implemented processes for data sharing, and we are also sharing via neutral broker platforms such as Vivli or CSDR. I don't know if some of you are familiar with those platforms. They kind of centralize clinical trials metadata information from multiple sponsors, and any researcher can log onto the platform and request data from multiple sponsors, submit a research proposal, which will be evaluated by the different sponsors as well as by an independent review panel. And then if everything goes well, the databases will be anonymized, and the researcher will be able to run its research proposal based on the clinical trial data. So I think maybe it's an example, and we know it's a little bit simpler, but also it's very regulated, so that does help us, and probably say that we also need regulation when we want to share patient data or even healthy people data.
Okay. So I think, Mr. Dollars, I think you have something to say about that. Yes.
You know, I know that the time was limited, so I took some notes.
No, it's okay.
Because Peter yesterday told me, you know, we have to be to make sure that we are on time. So I may be the black swan of this panel.
Yeah.
But you know, so I'm a producer and a user of genomic data, And genomic data in the world of this data is very sensitive because it's identifying people immediately. So my remarks will be angled, because of this background. So basically, I have three messages. First one is data sharing is not only limited by regulatory constraints. We are not very proud of that, but a lot of time it's because of competitive issue and unwillingness of scientists to share their data. And if we don't, look at that, we don't put that on the table, that will not work. Point number two is GDPR is good. It's my, I would not believe I would say that one day, but I fully agree with Peter that if everyone is following GDPR, provided it is simplified at some point, it needs some improvement. It will definitely ease the data sharing in Europe because everyone will be simply following the same rules. And my third point is, and I will talk a little bit more after. My third point is, stop with the buzzword. We talk about AI and everything, analysis, multiomics, but if we don't have technologies and infrastructure, we will never get to the stage where we will do this nice analysis. So we need to build the basic, build already the basement before we dream about the rest. So I can, talk more about that, or we can move forward. Laurent, how do you want to share? Sandrine is back.
Yeah, but she's still on the phone. Can you hear us, Sandrine?
Can you hear me or not?
Yes. Yeah, so maybe you can come back with what you were saying about the consent and data consent, patient consent. And then we'll come back to the data sharing with Peter. We have something to say, of course.
Yes, I don't know. It's useful, but I would like just to share that we absolutely need to inform before the consent, but also after the consent, all around the use of the data. And this is not for personal information, but for global information. So that is very important that we have a great communications on those systems that we are going to implement, that we already have implemented. Because right now, what I see on the ground with citizens is that there is a lack of trust for some possibility of misuse of those data, of hacking of data, and so on. And so if we have the technical security background, we can explain with a very easily word how it is done. And this is a way for trust, for implementing trust between citizen and the system. So that is the first thing. And the second, we need absolutely to communicate for everyone. That means that we need to adapt the information to every public. And for example, we need to translate the information we elaborated. And I try to work on this problematic because we know right now that we have so few documents translated in our system, in our French system, or in the population. We have some people not enough fluent in French to understand what we propose to them. So we absolutely need, for example, to translate, to have easily to read documents, like FALC documents, which means able to be read by people who are not who have not a literacy level sufficient to understand complex systems. So that is a point of which is very important to have in mind.
Okay, yes, thank you very much. That's very important. That of course we have to give trust to patients, which is not very easy sometimes according to level of understanding. But anyway, so just to come back also about data sharing, I know, Peter, you wanted to have to answer to Jean-François about infrastructure, about GDPR, about all.
Jean-François is absolutely right. This is not a technological problem. This is an organizational problem. And this is a problem of attitudes. And the key word is trust, that we're all using here. People need to trust the systems that they are privacy preserving and that they will protect their data. Just to describe you in a very short way what I've been doing for the past 4 years, developing a privacy preserving digital health system. We heard from our Danish colleague about the CPR, citizen card in Denmark. We've done the same thing. We're giving each person a unique number that is also an encryption key. And the citizen can use the encryption facilities available to him, to her, to encrypt the data and to control usage of their data. We are giving more power to the citizen than anybody else in all the systems that I've heard described. And we're perfectly aligned with the values of EHDS as a result. We want to do what Nathalie is doing with clinical trial data, we want to do with real-world data. And that means that we want to increase sample size by 2 to 3 orders of magnitude. Ambitieux.
So Nathalie, maybe something to answer to this ambitious needs.
No, I do agree, and I think in terms of security, what we're doing with clinical trials, we are anonymizing the databases, so we are never sharing personal data. We are also recoding sensitive information. If it's too sensitive, the information is redacted from the databases that we are sharing. And also, on top of that, I think it's important to understand that the data is not posted publicly. It's made available for some researchers for specific research projects. And they have access to the data for a 6 months time period, can be extended to 1 year, but the data is never made public. So that does also, that allows us to control the risk, to monitor the risk along the course of the project. And I think that's a very important aspect. We're not talking about putting even anonymized data in the public space. It's made available for specific research purposes.
Okay, yeah, Jean-François, please.
So I may come back a little bit on, on the normally what should be a virtuous line between, what the patient wants and when it's coming back. And sometimes, sorry to come back about this competitive issue in science, but this is a true one that we want to avoid because we're not very proud of it. But, COVID was a good example of data literally sequestered, by some scientists and physicians. Not shared, at the global level, not for the benefits of the pandemic. So we all saw that. So it was a disaster, that really showed that we have to do something next. And coming back to what Sandrine is saying, as a patient, when the patient is in an informed consent, it's okay, I'm okay to share the data. What we don't know and what we see is at some point there is a physician who says, okay, no, I'm not going to share the data of this patient. Even if the patient is okay to share the data, there is someone else who decides for his own reason, which is essentially, what his own research in the future. He keeps his data for himself, and these data are not shared. And I guess in the US, for example, as far as you are funded by NIH, you have a very limited period of time to put your data into the public domain. We don't do that. We should do that again and again. We know this tool. We don't use it anymore. We have to be more coercive. I don't know if it works in English or coercive, to oblige, to put the data, provided, it respects the wish of the patient, obviously, but into the public domain as soon as possible, but by respecting a time frame, protecting, the one that has been, getting the money to produce this data. It cannot be for tomorrow. But we have even example where data were generated, because of a government. No review, no process, no science. Government put 10 million to produce data, and the data are not, freely released for the community, this is absolutely unacceptable. And we even not use, the simple tools we have to force, the data release more. When it is so obvious like that, we even don't do it.
Yeah, that's a very, very good point. I don't know, maybe Sandrine on that, because I know about what was saying Jean-François. What do you have a point on this?
Yes, totally. I was wondering if it could be possible to have like a commission able to, for different databases, which are everywhere, that each of those databases have a commission which could be composed of professionals, institutional, private, but also citizens, to have a look on what is done on those data, and as Jean-François explained, to be sure that they are used as they can be used. That means at the maximum of their utility. And it could be a good point to have a kind of independent commission who can have a look on those different situations to solve perhaps and to help also professionals to have a new idea on the use of those data. It could be a great idea, I think.
Okay, thank you. Maybe Peter on that. What do you think about, as a CEO of a company, do you think a commission can check that? Yeah. What do you think?
No. No. I think that there's been enough time for debate and reflection. The time is for action now.
I finish, I think.
The legal framework is there. And one word about EHDS. EHDS is not game-changing. EHDS is revolutionary. And Stella Kyriakides is far in advance of the Council, of Parliament, and of Member States. And our responsibility of citizens, as citizens that have a lot of knowledge, is to influence our governments and our member states that they have to unite, follow the principles of EHDS, and go into action. Because if you think about it, look at large-scale data processing. Started in the 60s to simulate atomic explosions. Then a lot of use in meteorology. And then today it dominates consumer data, Facebook, social networks, health. We are doing nothing with health data except discussing endlessly. We need to move. The legal framework is there. The science is there. The technology is there. Let's stop discussing and act. And I've been doing that for the past 4 years. Okay. Ready to move in Portugal to 500,000 users.
Perfect. Okay, Sandrine, maybe, I don't know, you react. Or maybe, I don't know, if you have any...
Perhaps there is a misunderstanding. It's not a reflection commission that they want to implement. It's a commission to be sure that the use of the data is used properly and sufficiently. And to be sure that, as Jean-François Deleuze said to us, no data are stored by some of the different professionals, private or public, and not used. That is the point. Donc, I agree.
Sandrine, I went to see the Minister of Health in 2013 and discussed the incredible opportunities of secondary data processing. And he said it was a wonderful idea. He didn't do anything. So I did my startup in 2018, doing essentially what should have been a state project, and a private company is doing it. And now I've gathered 20 organizations that believe in the project to go ahead. So the state is not effective at making this kind of initiative. The states have given enough evidence that they don't have the means or the resources to make this happen. So let's see who's right.
Yeah.
Plus, patient organizations, citizens need to be involved also, and not only the state.
Absolutely. Yeah. I think it's a balance between to go quick and to go and to have a patient data consent. It's difficult.
For rare disease, for example, Patients Association made a very good jobs with private company and public also, and the state. So I'm sure that we need to involve them at any time it's possible.
Okay, great. Okay, we are close to the conclusion, I guess. Yeah. So just because I know we have maybe some idea for the future, or I don't know, Nathalie, because we talked yesterday about synthetic data, if I remember well, about pseudo, I don't remember.
Pseudonymization.
Pseudonymization. So those two. So if you can elaborate on what you think could be the future in your for clinical, but also for people.
Well, I think for clinical, we are already sharing clinical trial data for secondary use. Still, we have lots of challenges because anonymization of cohorts in rare disease is very uneasy to do, because as soon as you anonymize, you lose a lot of data utility. So there are lots of challenges. Of course, people in the rare disease area are more willing to share, but that's exactly what was said earlier, is that you get easy consent from patients. I think there's a great challenge to get consent from the healthy population. And I do agree with what was said earlier from our colleague in Estonia. If you want to be able to diagnose early, you also have to collect data from a healthy population. And I think that's also going to be a great challenge, to collect that information and to get consent for sharing that information. You're not a patient today, you might be a patient tomorrow, but it's hard for somebody who is not sick to think about what will happen when that person gets sick. And I think that's a great challenge for informed consent.
Yeah, this is the same thing for legal. We know. Yeah. And maybe Jean-François, what do you think about the future? What do you need? Where we should go? What do you think? It's for you, I know it's for you that.
No. And, already, as Peter was saying, use the tool we have, because we don't use, for example, the legal frame we have, and that's good for the people, for example, to share. I guess, we are reinventing the wheel in the last 20 years. I would agree with what he said. I was in the pharma business before to come back to academia, and when I listened to the talk about, we will make herbs and share, etc., this is exactly the same story we talked about since 20 years. So we have not moved so much in 20 years. What is pushing us today is the genomic revolution. And this is because, genomic data is so sensitive that all these issues are coming back. But it's even very complex with clinical data. Have you looked at, we talked about, data, but we don't put words. Okay, what data are we talking about? Getting clinical data out of an hospital, even between two French hospitals, is simply today a nightmare. They simply don't talk with each other. So my first point is, solve some key roadblocks we have nationally already, before we talk about what we can do at the European level. And also think about, infrastructure, and a bit, using what we have to facilitate, this data sharing.
Okay, great. Peter, now?
Last 2 points. Consent from healthy people. We're opening our ecosystem to application developers for healthy people, nutrition, fitness, parenting, so that parents can follow the evolution of their kids. And when they become sick, they're already in a system that also helps them to monitor their health. So that's how we've come around that problem. The second point about pseudo-anonymization, pseudonymization, we probably have the most sophisticated implementation in the world for pseudo-anonymization, in that the data is anonymous to us and to the researcher, no name, but when it reaches the doctor, through the action of the patient, it is associated with the name. We re-identify the data again. No one else has been able to do that. We've patented this, and the patent has been granted.
Thank you very much, Peter. And now the final word to you, Sandrine, I guess. It's, okay, I guess it will be balanced between patient and what we need to do. Still, okay. No.
It's okay. Okay, so data are useful for imagining, producing new knowledge, but we need to prove it and to communicate on it. The system needs to be safe and accessible to all, and this is very important. We need to be sure and to produce a system which is useful to everyone, every citizen, even the most vulnerable. And so it is very important to have an equity of access. And this is a very challenging point because it's not so easy. But I know that every private and public actors are working on it. But this is a very challenge we need to solve. And for this, we need to be helped by citizens because they have a lot of ideas, there are a lot of good elements to share with us when we think about how to produce a system which is accessible for everyone.
Okay, thank you, Sandrine. I think we will finish on that. Oh, maybe Jean-François. Okay, so yeah, maybe you have some questions from the audience. No, you all agree with what we have said about GDPR, about data, pseudonymous data. Everything is clear? Yeah. For me, it's not so clear, but if it's clear. No, but we can see the difference between company, clinical, philosopher, researcher. It's a lot of data, a lot of work still to do. We try to be quicker than before, as far as I understood. Let's see. Okay. Anyway, thank you very much. Alexis, maybe. Sandrine, thank you. Yeah.
Yes, thank you everybody, because it was really a difficult task.
It is a task.
To see all those topics in the same, but I think it's really important.
I think it's interesting. Yeah.
It's really important because I mean, the process of EHDS just started. So you have to raise those questions at one point. As Peter said, there were a lot of discussion for a long time, but then now it's getting really started. So if you don't ask those questions now, what's the point? So thank you all the panelists for your time and for your interest into this subject.
Yeah, but it's a subject for everybody, in fact.
It's a subject for everybody.
We are all citizens, finally.
Exactly.
Merci beaucoup. Merci beaucoup. À tout de suite, on va manger ensemble.
Because we are running a bit late, but we catch up the time a bit. We will start the third session now. So the third session is about the preparation of joint declaration between Scanbalt and Genopole. Scanbalt, as you know, is representing different organizations, biocluster, and tremendous work has been conducted by the digital group of Scanbalt to analyze first the proposal from the European Commission and to try to emphasize the key points of this proposal. So this session is more about trying to underline the aspect that could be really interesting to discuss it more. And for that, I will ask Janus to come to introduce the declaration. And of course, I would like to thank all the panel from the digital group who elaborated this declaration. So Janus, please, if you want to say a couple of words. Yes, please.
Thank you very much.
Yeah.
And our next panel is actually meant to introduce what we have done during last month. And the digital working group on the Scanbalt has been active, as I said already, for some years, led by Oliver Stenser
led by Oliver Stenser from Novartis, Germany. And there is a lot of very enthusiastic people. So this specific document has been now drafted by the digital working group, but specifically there is a group of people which were actually included into a drafting committee, which was supported by Max, who is actually sitting here and who has made a lot of sort of work with this. So if we can have this file here.
I'm working on it.
Okay.
Sorry.
So we shortly about the history. So as I said, we actually were drafting the same type of initiative document 2 years ago for the German presidency, which ended with a declaration. And this was not created by a small group of people, but it was actually based on the wide opinion, sort of collected from different clusters around Europe. And this time we wanted to see what has actually happened during these 2 years, during, of course, pandemics, but also on the background what we have now. We have a lot of developments, and there is also, as it was mentioned today already, the communication from the Commission, which actually gives us a good basis to see the progress. And that's why we were looking to the different aspects and trying to see what kind of sort of summary we can do, what kind of still open questions we have. This is not just to give any final answers, but it actually, as it was said, there's a lot of issues that has to be discussed before we enter to the implementation phase. And also, I personally feel that the European Common Health Data Space is a journey. So it's just we are starting the journey, and this means that we have a lot of issues that we have to discuss among each other, coordinate, and this first step and first sort of implementation phase will be rather to find the minimal common denominator, which we can start with, and then build on this, because as we have seen, there are different parts of in European and different countries have quite a bit different approach and cultural background. Peoples who, for example, in Estonia or Nordics are maybe more willing to share the data than maybe some people from other countries. Maybe there is some historical legacy for this from maybe the times back from 70 years in some countries. Some countries we know have their sort of unique identifier for each person, like we in Estonia or in most Nordic countries, which makes it very easy to actually identify the person, but also connect all data with this person. Some other countries, as I've been in a couple of years or 3 years ago in one conference in Germany, where actually the full conference was about different ways how to transfer health data from the health provider to another health provider. There was even the one startup which had a mobile phone application. The person went to a doctor and then put their mobile phone to the special sort of pad which loaded the data to his or her mobile phone, and this was actually the media which was was transferring data from one from a healthcare provider to another. And there was tons of other applications, which for us in Estonia is we don't understand this, because it's normal that data are actually somehow transferred from one place to another. That I can command and can control my data. And government has to. So as you see, there is a lot of issues, but with no due sort of delay, I would like to introduce the panel, because I'm sure that the panelists will continue to elaborate this. And in our panel now we will have Alexia Turkulen from Health Region Cologne, and board member of German network of health regions. Then we have Christophe Lenot, director of research and platform from Genopole. Unfortunately, Christophe was actually planned to have here physically, but this morning he actually informed us that he has to be still removed because he got positively tested to the corona. So then we have Hille Hinsberg. He's a product manager from Estonian company Proud Engineering, and she has been closely digging into this European health data space issues with DEHTAS project. And also we have our old friend and collaborator and former representative of Västra Götaland region from Sweden to Scanbalt, Lars Lindsköld. He's a very knowledgeable person about health data digitalization and interoperability. And lastly, James Kennedy, who is a policy director of European Society of Cardiology. So can we have our panelists on the screen, or is it maybe we can go already to the panel, or we still can have a slide, perhaps. So how we structure, we have now 22 minutes to 1 o'clock, so we have approximately 35 minutes, and we try to go through main issues raised by each panelist. So this is like a very broad sort of overview what is our concept paper is actually covering. There's patient centricity and data protection, which is obvious, use and misuse of data, which was actually, Sandrine was actually very much emphasizing, semantic and technical interoperability, primary and secondary data, which is also, as I said, the main topic here. Institutionalization of a European digital and health data board, which is actually to bring and see how it actually will be supported by actual structures, and wellness data as more than a nice-to-have add-on. So these are actually topics which are covered by our paper, and this paper will be actually available for you after the conference. So we urge you, maybe you give your comments if you have any, and then we try to make it as soon as possible, maybe in 1 week, available for the French presidency, that it can be valuable input to the finalizing the presidency, but also to the next presidencies. So maybe we can have now panelists. Do we have panelists online? So we seems to have some technical problems. Which, maybe the last session people are getting tired. So. Hi, Christoph.
Christoph.
So maybe we can. If Christoph, you are already in a big screen now, maybe you can start to your part. What is actually important for you?
So, okay, yes, just I would apologize that I'm not able to join you at Genopole. So Genopole is involved in a way that how do you share data and how you are able to practically build an infrastructure to share data. This is as people are already said, GDPR and legal framework is already inside the world, and then it's applicable now. The question is that how we can do that in practical way. For secondary use, for primary use, it's obvious. It's also that this is something that we need to build, and in Europe, just because we have to share this data. To give the opportunity of European people to have access to the data for primary use, but also for secondary use, it's also obvious that it could be a game changer to have access to this data. The question is that how you can do that. There is 2 points that we need to think about. Is that as already told Jean-François, the question is that only if you are able to share, but how you are able to share from mesocenter to the mesocenter, and it's very important to understand that you need to build a network of network, and not only just centralized center. And you need to think about how you practically build a network able to share data from mesocenter to mesocenter in a way that people on the former panel roundtable said, in a trustability, in transparency, and fair way. And also the citizen-centric, which is a key point, is also something that we need to take into account, and this is something that we need to think about, and how we can build solutions that are able to share data with the maximum security that we need to do, and with the GDPR aspect, and also bring to the citizen the power, the empowerment to share the data.
Thank you very much. Thank you very much. So, Alexia, so you probably can give us input and your views. What kind of different levels of data sharing you could see?
Absolutely. So first of all, thank you very much for the invitation. I'm Alexia Zukulin. I'm sitting in Cologne in Germany, and I represent today both the Health Region Cologne-Bonn, which is a members association uniting actors involved in the healthcare sector in the region, but also the Healthcare Region Cologne-Bonn is part of the network of the German Network of Health Regions. And that German Network of Health Regions is associated with Scanbalt on a number of ideas and projects. I think we think very much alike. And we were invited to also give feedback to the joint declaration and contribute to the elaboration of it prior to today. So again, thank you very much for that opportunity. And also, in French, je suis désolée de ne pas pouvoir être avec vous à Évry aujourd'hui. J'aurais beaucoup aimé être là. Je suis franco-allemande, donc ça m'aurait fait très plaisir de retrouver un peu la région parisienne, mais ce sera pour la prochaine fois. Thank you very much also for that. Right, so from our perspective, and I guess the point that I really want to make, and Janos, you've mentioned it before, not all the countries are as keen on sharing data, and not all the countries already have a framework which allows, like Denmark, and like an example for sharing data. And so I would be as bold enough as to say that Germany is one of those countries, neither as keen as on the sharing front, nor as advanced on the interoperable front either. And so what we have learned at the Network of German Health Region, and in our region in particular, is that we were benefiting at a very great extent on sharing opportunities at the regional level. So this can be just across the border. So Cologne is not particularly close to the French border, but it's kind of close. But the region itself has obviously parts of it that are quite close, for example, to the Dutch border, and that trans-border data exchange and in terms of primary and secondary care, or in terms of primary and secondary use of data, actually has proven to be very beneficial for those border populations. But beyond that, those are the levels that I had mentioned in our pre-talk relating to today's conference. The levels on which we have noticed how important it is to share data, and they have been mentioned today, but we really can relate from our, as a members association, we are a civil society organization, so we represent different branches, different sectors within the healthcare sector. And so we not only are obviously not patient representatives as such, because we also represent the medical professions sometimes, but we also represent the public authorities sometimes, as well as the private sectors. Our members come from all those sectors, but as such, as an organization representing the interests of all our members, as diverse as they are, we can say that the scientific level of that data exchange, the knowledge gain, the knowledge transfer is so important, and it brings everyone forward in terms of developing innovations, testing those innovations, learning from other members, other sectors, other associations that are doing the same thing, bringing back those information and that knowledge into our home region. This is something that we can really tell off a lot, and I will have a couple of examples for you in a minute. Obviously, on a medical level, on the provision of healthcare services, health and care services, really, this is such also a gain for population, and then again also the secondary use of data in terms of population health management. And that, I think, if we look now in the future and if we see where the journey is going, I really like the, you just said EHDS is not an achievement as such, it really is a journey. And I guess this is something that we can all relate to, and every speaker today has more or less said that. In terms of steering population health management in knowing the needs, it is absolutely essential to promote that space and to protect it and to foster the trust, as has been said before. I would just like to conclude my first intervention here with a couple of examples. What EHDS seems to be doing, and what we welcome obviously, is creating that framework for having sustainable structures for tests or projects that have been happening at a much smaller scale before. And this is also what we've heard all morning, and it was fascinating listening to all those different facets and all the gains that have been brought by different initiatives already. In our region in particular, I would say that one of the greatest benefits that we could gather by exchanging data within European projects has been, for example, within an EU project called SHAPES, where we have a pan-European piloting campaign testing different connections in between older adults and technologies, mostly in their home care in their home setting, but also in the nursing home setting, and how they actually how that relationship builds on, and how the health parameters, the well-being parameters, and obviously then also the treatment of different diagnoses have been improving or are improving over time. This is currently ongoing, and they're all very small test pilot, but they are pilots in smaller settings because they're set within European regions, but the richness, and that's why we call it the pan-European piloting campaign, is the exchange of that information and the replicating of those use cases in similar regions or very different regions, and noticing what difference comes across and analyzing those differences. And I guess that knowledge that we gather from those projects, from those European projects, is all very, very important information, and that we all be putting towards obviously building up that and going onto that journey together and building up the European health data space. I'll come back if some more later. I know I've already probably talked too much, so I'm very happy to respond also to any questions regarding those regions and the health regions networks and the civil society perspectives on that later.
Thank you so much, Alexia, and we surely try to have some questions later if we have been doing the first round. Hille, you have been dealing more with secondary use of data, so it would be great to hear your reflections on this.
Thank you, Jaanus, and it's a pleasure. I've been listening with great interest and attention to the morning sessions. Thanks for sharing, and I'm taking this opportunity to share with you the insights that I have collected and sort of filtered from several sources. One of the sources is the EHDS project, and you heard Markus Kalliola before, but they have also conducted pre-EHDS kind of as-is situation of challenges that the ground level, the service providers, the health application builders are experiencing still when it comes to any kind of sharing of health data, including primary and secondary purposes. And the other source is EIT Health, which has done similar exercises in bringing out the challenges when it comes to real practice, again with service providers. And then on top of that, my own research, being part of the connected health cluster in Estonia, the quadruple helix, including very small startups, but also very big providers of health and care services. So my points are to actually use this regulative opportunity as a chance to do some housekeeping. What I mean by it is that the sources that I listed for you highlight that, I would say, 50% of the challenges that the service providers counted were related to legal context, so external conditions. And we know that the health data space is aiming and targeting to overcome these, at least partly. But more than 30% statistically was mentioned as problematic data management. And that is internal within the organizations. That is the housekeeping that I'm bearing in mind. So the how data management practice, data flows, control over data is organized within the organization is, in my view, of great importance and serves as an enabler to begin sharing of any kind. So you probably agree that, and I think it has been talked about, data quality. So data quality is probably the easiest way to ensure it is to control it and to take a responsibility for data quality at the time and at the point of entry into the whole ecosystem. Meaning, again, the ground level, the building block of either the health application, technology provider, or the health and care service provider organization. So in that view, we are counting terribly on the control and steering mechanisms down on that ground level. And I think the responsibility should be there, but they should not be left alone in trying to come up with ways to take control of data provenance, to have some kind of certified data quality, to put the meta labeling on data so it can be traced throughout the further flow of sharing. So I think the roles that come in there demand a great improvement in the data management systems in those organizations, and also some kind of robust support, either by the member state level or preferably by the European Union level, to come up with kind of agreed upon and really robust way of certifying the data quality, maybe guidelines as to the metadata handling and labeling, and then of course distilling it through to the very ground level of very micro size organizations that have come up with brilliant innovations that are piloted and tested and then taken into a scaled use all over Europe. So what I'm trying to put here is that there is a wonderful enabling opportunity formed and will be implemented, I hope, in the nearest future as the common health data space. But it really needs a lot of effort to take it down to the very level that we as patients, we as citizens and as data subjects, of course, come across with. So some kind of agreement, also relying on the initiatives that are already out there, be it kind of more technology-oriented initiatives such as the open electronic health record or semantic interoperability initiatives, that these should be reinforced and empowered to get wider ground. And I think the common regulatory context would be very apt to actually do it. And I think these are the two thoughts that I would like to share with you now. And of course, looking forward to discussion.
Thank you very much. Thank you very much, Helen. So there is even applause to your statement, so that it's reflected very well. So James, what about the view from a specialty, which is of course one of the importance, and because cardiovascular diseases are one of the most sort of prominent what we have here in the society nowadays, which is one of the main cause of death. So can you reflect on what these cardiologists are thinking?
Certainly, and thank you very much for having me. I'll try to keep it to about 3 minutes. So with the EHDS proposal that we have on the table today, this is probably the first time in my career that I've ever picked up a piece of policy and thought, I'm actually quite fine with this. And if this went through the way it is today, I think it would be enormously beneficial. Judging by the position papers of a lot of other health organizations and specialty groups as well, it would appear to me that people agree that this is going generally in the right direction. There are caveats and there's concerns, but there's been no major colossal red flags of everybody saying this is a disaster. And considering the ambition of the EHDS, I think that's an incredibly encouraging sign. From a cardiology perspective, a lot of the potential benefits that we've heard about of the EHDS today to fundamental research, patient care, patient safety, these all apply to cardiology as well. But I'll pick one in particular that I'm enthused about, which is registries and cardiovascular disease registries at EU level. For the last 10 years, but it really picked up pace in the last 5, every pathology, diabetes, cancer, cardiovascular disease has been calling for the creation of EU registries, and that any of the things that we want to realize at EU level in personalized medicine or cross-border healthcare are going to necessitate EU registries to do that. If we couple the EHDS with the EU for Health program that we have on the table today, which increases healthcare funding in the EU from 550 million over 6 years to spending 1 billion every year, I think we could see in the not so distant future the possibility that we will have a fully funded EU cardiovascular health registry at EU level and for other pathologies as well, with all of the benefits of unparalleled understanding of cardiovascular disease, comorbidity, multimorbidities, and who knows what else. I think that's the exciting thing about gathering data in this kind of way is the undiscovered part. A few practical concerns. One is the budget. I never thought I'd bring that forward as a consideration. But the Commission's estimate seems to be extraordinarily conservative to my mind. I'd like to point out that the UK track and trace system for COVID cost 15 billion in 12 months and it didn't even work. But we're going to roll out work towards a federated data network with a common data model across 27 countries with different systems at regional and national level. And it's going to only cost a couple of 100 million here, a couple of 100 million there, and some member state funding on top of this. I think unless member states put forward the right resources to this, the delay in the rollout is going to take place long after the legislation is passed. So that's something that we need to take into account. A political, but I think no less practical consideration is going to be who is handling this from an institutional point of view in the European Parliament. It's not going to be the Research Committee. It is not going to be the Health Committee. It's not going to be the Internal Market Committee. It will be the Civil Liberties, Justice and Home Affairs Committee. So the same people who handle the GDPR legislation as well. Now, veterans of that debate, and I had a lot more hair when that was going on, will remember, just how difficult it was to explain to policymakers the difference between data security, data protection, cybersecurity, data privacy, and these types of things. And explaining that, you cannot improve cybersecurity by making it more restrictive for people to share their data. That's not how that works. These types of things. And their background in the Civil Liberties Committee is all on regulating big tech giants, on Apple, Facebook, Google, and protecting. They're not going to share our enthusiasm for what this could do for healthcare research in the EU. And I think we should be very clear about that. So we're going to need to come up with some very plainly spoken, clear language to explain extraordinarily complex topics. That fragmentation at EU level when it comes to data networks is not a matter of expense. It's not a matter of difficulty. That the kind of things which they are looking to accomplish and the free flow of exchange of data that they're looking to do will be impossible without a proper functioning European health data space. And we need to communicate this to them. That said, if we're vigilant about the progression of this legislation and we don't take it for granted that everybody is going to share our view on this, I think the EHDS could be one of the greatest research opportunities at EU level that's perhaps ever taken place, and not just for cardiovascular disease, but for the entire health sector. So we're very excited about what this could do. We have reservations, but I think like most organizations as well, think these are things that we can overcome if we stay vigilant about its progression over time. And that was 3 minutes, 20 seconds. Stop there.
Great job, Trent. Thank you very much. And I think this valuable insight to the Brussels sort of kitchen, as I might say, this is also very important to understand, although the key, I think, is still with the member states, because whatever will be approved in Brussels has to be ratified by the national parliaments, and this means that it's obviously will not pass if there's a clear that some of the member states will not agree with this. So Lars, you have actually like probably dual view, as you are coming from a country which is considered to be highly socialized, and then I mean the healthcare in all Nordic countries are well known, and the sharing has been on the top of the agenda already for a long time. But at the same time, you have a lot of sort of stuff to do also with pan-European or even global view for the digital health. What is your view on this?
Thank you, Janos. It's a great pleasure to share a moment with you guys, and I must say thank you to the panelists. I learned a lot just listening to you, and it's not easy to be the last one on the panel and try to fill in with some new knowledge there. I think that what I'm a little bit interested in and I start thinking about is what's the reason to share? What is actually the way that we can convince each other that we will win something if we share something? And that's a rather difficult question to ask to yourself as an individual in the municipality, but also to you as an organization. Because as today, I think most of all think that it's an asset to have a lot of data. And it might be in the future that it could be better to have a lot of data products. And the data product by itself could gain something for someone else. I used to joke about this sharing is caring. And I think one of the first steps I have learned is prepare to share. It's all about care. And that's something I guess all of the countries in Europe needs to understand now. What will our common language be? How will we communicate our results, our data points? It's not just opening up something and it will work. It will take us, as both Hille was stressing a lot about the quality of data. How do we address that? The second part I have understand, because I'm an old man now, is that I'm sharing who cares. We have heard a lot of solutions presented here today, and I know a lot of solutions around in the whole of Europe saying, well, I have the solution. Why can't everybody just do what I'm doing and we would fix the problem? And I think that's really something we need to think about, that when we are building an infrastructure, it's not to release a platform. That's very, very important to understand. And I'm also a little bit interested of why we are just sharing in Europe. Do we think that the European citizens will say, well, I will just share with Sweden and Denmark and Romania and Germany? No, they will probably share with the one that gives them the best thing back. And that's one of the problems we have today when we talk about sharing. It's just giving away something, but we can't really put the focus on what will be the results if we are sharing. If we're sharing all the cardiology data, how can we convince everyone that we will give you a better treatment of your heart diseases and so on? So that's when I talk about sharing is caring.
And that's the interesting thing, that most people seems, at least in the Nordic countries, be very interested of sharing their data if they can see it makes some benefits for somebody else, but not normally benefits for someone to be a millionaire in some pharmaceutical company or something like that. So that's the thing we have to weigh between there. And I'm also fascinated over the word space. Have you thought about it? The European health data space. I mean, a space is actually just something that is empty. And you can put things there and you can get things out there. So it's something we also need to discuss. How will we frequently use this space for things? And I think that when it comes to these fascinating things, data, it's for me really something that will never disappear. I mean, the data itself can be reused again and again and again. So in a way, I think we could start to think about health data as a part of our ecosystem, as well as the wind, as the sun, as the sea, and so on. It's something that will be existing, and we can take part of it sometimes, and we can stand behind it or at the side of it. So that's perhaps a little bit more philosophical question about this. Thank you.
Thank you very much. So we have 5 minutes still, or no? We have 5 minutes. Okay. So just to comment your sort of views on the data sharing or the cooperation, I recall that in early days when we started Scanbalt, then there was a sort of notion that what we created or developed was a competition, because we knew that all countries were somehow in competition, but sometimes we knew that we need a cooperation, and then it ended up with competition. So, but maybe we have sometimes some questions from audience. So our audience. If not, then as we still have 5 minutes, I would just urge you, every panelist, to give a short, like not more than 1 minute reflection. What do you think, what could be the most important next steps in this process, what we are now heading in the European health data space? What we need to be done most urgently and expediently? So maybe we start from Alexia.
Well, I would say secure a quick gain, and that would definitely be improving the quality of health service provision across borders.
Thank you. It was very, very quick and crisp. So, Hille.
Since the process is now going to be a longish one, each member state will sum up their own arguments in the consultation phase, and then present it to the committees and then the Commission and then the Parliament at the EU level. I would like to see rather lively and agile cooperation of professional networks. So I know this is one of the events that contributes to it, but really I would love to see action in thematic, technology-oriented clinicians and all sort of professional, enthusiastic networks to come up with their own support or criticism or some kind of agreements that can be cross-border level and can be presented in a ready-made form to enter this discussion.
Thank you. And Christoph, so yeah. Can you share with us?
Yes. I join Alexia. The first step will be the primary issues. We need to build a network of an infrastructure to share data for practitioners. So and this will be the first point, because we need to have access for healthcare practitioners, but also that to think about the way that we are building European and health insurance.
Thank you. James?
I just point out that from a messaging point of view, we need to avoid what happened with the GDPR, which is a conversation about access to data for healthcare research and data protection. These conversations run in parallel, and they never properly met. So you would have politicians who were responsible for data protection policy talking about how we need to protect citizens as much as possible and make it as restrictive as possible, et cetera, et cetera. And then the same politicians will go across the room to talk about the clinical trials regulation and then say, isn't it a disgrace that companies are holding on to all this healthcare data? They need to open it up to everybody. And they never really hit home that these things exist together. So I think from a messaging perspective, we need to be clear that the rights of citizens exist in a spectrum. Yes, they do have a right to data protection, but they also have a right to good quality treatment. And we need to make sure that for policymakers to understand that these things are heavily interconnected and you cannot try and regulate one without the other, that you do have to have these conversations at the same time. So more of a messaging angle, I would say.
Thank you very much. And well, maybe Lars, you can now also end up with some philosophical thoughts.
I think it's good what have been said there. I like Christopher says the network of networks. My feeling is that it's not politicians that really change the world. It's not only professionals that change the world, it's the people that lives in the world. And the universe is not built by rules, but it's built by opportunities. So I think that one of the greatest thing I see today is that probably the machine readable will be the future of Esperanto. And therefore, it's like Hille discussed about, we need to organize to find our metadata repositories and share them, what we have to share and so on. And we can start to build more business around it and great benefits for the citizens. Thank you.
Thank you very much. And I really appreciate the panelists, and maybe we can give the panel to applause. So thank you very much. And maybe we now just go to finalizing the event. And
exactly, Janus, I think it's time to finalize the event. It was really dense, I think really interesting, a lot of learning during this event for everybody. So I thank all the participants first. I think the more important is really to thank the speakers, the panelists, and maybe Laurent and Janus, you want to say a couple of words on the behalf of your respective organization, because I would like to remind you that it was a joint project, a joint event together between Scanbalt, Genopole, and all the organizations that we represent. And I think the main learning in this for this event is that with the network of network, as Lars said, we can move to a European health in finally integrated space. So a couple of words, you two, if you may.
Thank you very much. And I really want to thank Genopole, Laurent and Alexis for the great cooperation. And I see that this is not, as a European health data space, is not the end, it's just a start of the closer cooperation, although we have had cooperation with Genopole already for some time. So it has been pleasure and very interesting journey to prepare this. And I'm sure that Genopole and the team can be with us for the next, obviously, the next bigger event. What we are looking for is in a year time, as I mentioned, during Swedish presidency, and we have already started to prepare it in Gothenburg at the Vitalis, which is one of the biggest events in Nordic countries for e-health. So I don't know exactly the date, but this has been already agreed that we are starting to prepare this under the Swedish EU presidency. But thank you very much.
Thank you, Janus. Thank you for coming from Estonia to Genopole. It has been a pleasure to have you and Professor to here at Genopole. We are very, very happy that everybody is coming from other countries in Europe. Europe is a political dream, I think. I'm a very, very European guy, even more at international level. Borders are bad, as we can see now. Border It's a bad invention from human being, and I think we have to stop to have borders. So maybe we can start with science. Science always been without any borders, and I like that. So with the data from patients is also very important. Citizen needs to be involved in science. It was not easy sometimes, especially with COVID. I guess we have all the same debate in all countries in Europe and in the world. Do I need to get vaccinated or not? It's always the question. And of course, I'm for the vaccination. I'm a scientist. And so we need to educate also the population. It's not easy also to educate population. Science is difficult. It's it's not easy. Science doesn't bring all answer for everything. It's difficult, and so this is why I think this kind of conferences are very important. We can see the balance between philosophy, science, data contents is very, very interesting. So it was very nice conferences with everybody, and thank you for joining us at Genopole in Paris. Alexis.
Thank you very much.
Yeah, thank you. Alexis, the final word to Alexis. We have done 90% of the work, so that's to you.
Thank you very much. Thank you very much. I just wanted to also thank our partners. So the French Ministry of Health, who labelized us for this event. Tremendous work, I have already mentioned it, but a tremendous work have been accomplished during the French presidency for the progress of the health data space. We hope that it will continue during other presidency, such one and then the Swedish one. Peut-être aussi quelques mots en français, puisque c'est un événement européen, mais également local et français. Donc, nous remercions également tous nos partenaires locaux, notre écosystème, l'État, la région, toutes ces personnes qui nous supportent au quotidien dans nos tâches de développer un biocluster et développer la science à la fois par l'entrepreneuriat, par la recherche et également l'hôpital que nous n'avons pas mentionné. Donc merci à tous, merci à ceux qui étaient présents sur place. Je sais que ça n'a pas été facile en raison de la météo et je vous en remercie. Et j'espère qu'on pourra networker et discuter ensemble pour voir s'il y a de potentiels area of interest, comme nous disons en anglais. Thank you very much. Thank you a lot and goodbye.
Thank you. And we have a lunch now. Huh?
We have lunch.
Yeah. What time is it? 1:20. It's time to go to